Good morning. Our program will begin in just 5 minutes. Please take your seats. Handicapped accessible seating are available along the sides of each row. Good morning. Our program will begin shortly. Please take your seats. Handicapped accessible seating along the sides of each row. Good morning. Our program will begin shortly. Please be seated. Handicapped accessible seating along the sides of each row. Good morning. Once again, our program will begin very shortly. Please take your seats. Handicapped accessible seating are along the sides of each row. Ladies and gentlemen, welcome to the 7th Annual Parkinson's Expo, hosted by Neuro Challenge Foundation for the Parkinsons. Please welcome Jennifer Bittner, CEO of Neuro Challenge, to the stage.
Morning! How are we today? Okay, come on, we can do better than that. We want Sarasota and St. Pete to hear us. Good morning! There we go, that's better. Let's get our arms up a little bit. We'll get a little bit of movement in as we get started, right? There we go. All right. Thank you all so much. I have to put my glasses on, guys, so bear with me. Thank you all so much for being here with us today. We have nearly 1,100 people participating overall here with us today and online, right? Round of applause. Fantastic. We love that. So we are so excited that all of you are here with us today. And we know that you come from long distances and make the travel, and so we really appreciate you taking the time to be with us. And in addition, as I mentioned, we have hundreds of people watching worldwide through our parallel live stream today, so fantastic. Now, where are our care partners? Show me, let's get your hands up, there we go. Big round of applause for all of our care partners and friends and family, guys. Thank you for making today a day to be educated, engaged, and empowered. Neuro Challenge Foundation for Parkinson's is excited to be celebrating our 16th year. Can you believe that? Fantastic, right? 16 years. We would not be here if it weren't for the generosity of our donors and sponsors, so please make sure you take time to visit with all of them today, because they certainly help make today possible. I want to give a special shout out to our diamond sponsor, Supernus Pharmaceuticals. Big round of applause for our friends from Supernus. And also our platinum sponsors, Amneal Pharmaceuticals. Thank you. The Observer Media Group. And our friends at Kiowa Kirin. Big round of applause. Thank you, guys. And special thanks to all the sponsors and the community resource partners that make today possible. Exactly. So be sure to visit all of them during the exhibitor breaks and at the close of today's program. So, I have a favor. How many of you have Facebook? Again, we can get a little exercise in here. All right. So, huge favor to ask. First, follow the Neuro Challenge Facebook page, and then check in that you're here, and then please take pictures and post them, because it helps us actually advertise and market this fantastic event, and it helps get more people coming to the expo and to our other programs. So you can help us by promoting what we're doing today just by using your social media accounts. So we ask that you do that, please, and we thank you in advance. I also would like to give a shout out to some special people. So many members of our board of directors are here today, so a round of applause for this really special group of people. And at this time, I'm going to ask a very special member of our board of directors, the most fantastic, fabulous, and amazing Brad Bryan, to join me on stage, my co-host for the day.
Thank you, Jennifer. Good morning, everybody. I'm so excited to see you all here. My name is Brad Bryan, and I proudly serve on the board of directors of Neuro Challenge Foundation. And I'd like to also welcome you all, whether you are with us here in the room or coming in via the live stream. Welcome to the 7th Annual Parkinson's Expo. Now listen, I want to hear from a round of applause, who here this is your first Expo? Okay, but maybe about half the room. Who here has been to multiple expos? Yeah, I want to see, has anyone been to every single expo, 7 expos? Yeah, amazing, let's give them a round of applause. And I'd like to thank you all and applaud you for being here today. Folks, we have a very exciting day for you today and an amazing lineup of speakers. I hope you can stay with us for the entire program because I know you're not going to want to miss our very last speaker, who is Kanwar Bhutani, an amazing guy living with Parkinson's who has a great story he's going to share, and you may have already seen him on Good Morning America. So that's a plug for later on today. I got involved with Neuro Challenge because my father has Parkinson's disease, and he is watching from home today along with my mother. So hi, Mom. Hi, Dad. Neuro Challenge has helped my dad and my family in countless ways over the years. He was diagnosed about 20 years ago, and so Neuro Challenge has helped us, whether that's finding a movement class, finding speech therapy, or just having someone that we can turn to ask questions about the complexity of Parkinson's. What do we do next? What do we need to think about? So it's been a very big blessing in my family's life, and we love having them in our corner, ready to help us whenever we need. Folks, I would like to also hear who here has already been involved with Neuro Challenge. Give me yeah. Well, for everybody, Neuro Challenge is a resource that's here for you. Everything that we offer to the Parkinson's community is free of charge. We have a table set up over there with staff ready to answer your questions, so please visit them throughout the day. Folks, thanks again for being here. I hope you walk away feeling energized today and educated and empowered. Now it's my honor to introduce Dr. London Butterfield, our first speaker, who will be presenting cognition and mental health in Parkinson's. Please help me welcome Dr. Butterfield to the stage.
Good morning. How are you all? Great. Well, I'm very excited to be here, and this is one of my favorite organizations, so I'm glad you have all discovered it as well. So today, I'm going to talk about the cognitive symptoms that some of you may have experienced, as well as some mood symptoms, and focus on not just what those symptoms may be, but also what can you do about it. So hopefully you leave here today with some education about that, but also knowledge about what can I do to navigate these things as I move forward. So as you all know, Parkinson's is diagnosed, at least at this point, primarily based on motor symptoms. And beyond that, there are several non-motor symptoms that exist that are not as obvious to others on the outside. And I want to add, just because there are these varied and many symptoms, not everyone experiences them. Some people experience one or two, some experience multiple. So there's a lot of variability person to person, as I'm sure you all have discovered. Today I'll talk about these mood symptoms: depression, anxiety, apathy, and also we'll touch on some hallucinations as well, and cognitive issues that occur or symptoms that you may notice. So let's start there. In Parkinson's, the cognitive symptoms that are most common are what we call frontal subcortical symptoms. It looks a lot different than somebody that has Alzheimer's disease or frontotemporal dementia or another neurological condition. In Parkinson's, one of the prominent symptoms that many people experience is what we call bradykhrenia. Just as you may notice a slowness in your movement, you may also experience a bit of a slowing cognitively. Not as quick to retrieve a word, not as quick to process information in a conversation. Attention is something that also is very common, being able to keep track and attend to multiple things that are happening in your environment at the same time. That gets difficult for everyone. But in Parkinson's, that's one of the other prominent difficulties. executive functioning has to do with many higher domain cognitive abilities, such as being able to multitask, being able to plan, to organize. You may not have trouble remembering which medications you take, but you may have trouble remembering or planning to order them ahead on time so that your refills come before you need them. So that's the difference. And with memory, we do see some memory difficulties, but it's not an inability to store information typically. It's more of a difficulty just retrieving, accessing that information that I learned before. I know we had a conversation yesterday. If you can jog my memory, it'll come to me. And that's typically the pattern of memory issues if they are there. Now, of course, there's a whole range. You may have some more difficulties, and you may have less. Some don't have any trouble with this, so it's really variable person to person. Visual, spatial, and language difficulties sometimes manifest too, spatial difficulties being more common. So for instance, being able to not bump into a wall when you're walking through a doorway, misjudging space, or if you're parking a car, parking a little sideways in the lines, that might be something that may happen. It's part of those changes in the brain that happen, and it's affecting that aspect of your thinking skill. In language is generally spared. It's not something we see as a prominent issue in Parkinson's, other than that speeded speech or speeded word finding ability. Now, when we talk about cognitive change over time, we think about this preclinical phase or this asymptomatic phase as an early presentation. I don't have any symptoms. I don't really notice any cognitive change. You may notice something subtle yourself, but it won't show up on testing. In fact, about 30% of patients will say, I do notice some change. I'm not quite as sharp. I'm not as quick as I was before, but it may not even show up on testing yet. So it's real subtle. As Parkinson's progresses, a lot of people will notice some decline cognitively. And we differentiate mild cognitive impairment, or what's called mild neurocognitive disorder, from major neurocognitive disorder or dementia, based on your functional abilities. So cognitively, if you do have a deficit compared to others your same age, which is important to point out because there is normal age-related change that happens with everyone cognitively, if your cognitive deficit, when I am assessing you as a neuropsychologist, that's oftentimes why someone comes to see me, is because they're noticing some change and they want to really characterize their cognitive abilities. Is this change that I'm noticing normal for age, or is this due to the Parkinson's or to something else? And so we'll classify mild cognitive impairment or mild neurocognitive disorder if there is a deficit for age, but it's not yet impacting functional ability. So you're able to keep track of your appointments. You're able to keep track of your bill payments, for instance. It's not affecting you functionally in a significant way. Whereas in dementia, that would be labeled if, yes, there's also cognitive deficit, but now it's impacting my functioning. I really need to rely on someone else to manage those things, or else I will make too many mistakes. Now, if someone is using some compensation strategies, they are noticing it's harder to manage their medications, for instance, but they can do it by using a pill box or by writing them down, then we might still consider that mild. We wouldn't really consider it dementia unless you couldn't even do that either. Now, I'm listing some prevalence rates here, and I want to say there's some sort of hot off the press, actually it's not even in publication yet, but there was a talk by Dr. Weintraub just weeks ago, and there are 2 large-scale studies that are looking at the prevalence of dementia in Parkinson's, and these newer studies, because a lot of the data that we've been looking at are really getting older at this point in time for rates of dementia, and these newer studies are larger scale studies, and they're showing more promising results. So it's really good news. The prevalence rates of mild cognitive impairment that we have been using for a little while now are about 20% at diagnosis will notice some mild cognitive impairment. After about 5 years, it's 40% to 50%. And dementia is diagnosed at about, let's say at 10 years, about almost 50%. However, this new data is showing it's about 25%, maybe even less, maybe as low as 15% after 10 years. So it's very good news. And I think that leads really well into the next slide that I'm going to show you. There are different reasons for this, for why these newer studies are showing lower rates. Part of it may be there are more younger onset individuals in those groups, and the progression for younger onset is a little slower, and the cognitive deficits are slower to emerge. But also, I do wonder, is it because we're also, as a population, we're learning so much about the benefits of exercise and these lifestyle activities that can help prevent or delay dementia. And perhaps that's manifesting now in some of this new data. So what can I do? Let's review that. What can I do to protect my brain, to protect my cognition from decline? Number one is really to protect your heart, because anything that is good for the heart is good for the head. You want to watch out for any issues that affect your vessels as well, so blood pressure, diabetes, sleep apnea is another one too that can cause some cognitive issues. Physical exercise, I know I'm not the first and I'm not the last person to mention this, and I'm sure all of you know this already, but I want to urge the importance of this because physical exercise helps with cognitive function. Individuals who exercise more aerobically, especially cardiovascularly, show a slower decline over time. It helps not just physical function, but also your mood and your cognitive ability. When you exercise regularly, your brain releases a growth factor called brain-derived neurotrophic factor that can protect your brain cells. So it's extremely important. You can research this on your own, but it could be a whole talk on its own as well. There are many different options here too, and I want to encourage you to find something that works for you. Don't give up because you feel you can't do the exercise you used to do. You can tailor an exercise, find something new. You could swim, you could do water aerobics, you can canoe, you can do Tai Chi, you can do cycling. And there are a lot of programs geared toward the Parkinson population for this specifically, some of which are represented in the vendors out there today. Social engagement and mental engagement, I encourage that too. Make sure to join classes. You're already learning here today, and that's an important piece of protecting from decline. Hydrate. You have to have water. Your brain won't work right. You have to eat. Your brain won't work right. You have to you have to have sleep. So those are sort of the basics. And then reduce stress, because stress can actually counter a lot of those benefits and cause additional memory issues. Prioritize your psychological health. It's not uncommon for people to be afraid to mention this or shy to mention their psychological symptoms to their doctor. And sometimes it's not inquired about at the visit. If that's happening, where it's just not something that you've mentioned to your doctor, be sure to do so. And I'll talk a little bit about why that is in a bit. But first, let's switch to some compensation strategies. What can I do if I'm having some memory trouble? I want to cover a couple of ideas here, suggestions. So Memory Power is an acronym that I created that will maybe help you to remember some ways that might help improve your memory. First of all, pay attention during learning. If you're not attending, if you're too tired, you're distracted, if you have too much clutter in your environment, those kinds of things pull away your attentional resources. And with Parkinson's, it's not uncommon for your attentional resources to be more limited than they were before. Organize the information, cluster the grocery items that you need from the grocery store, the produce, the paper items, the meat items. Organize the information in whatever way you can in order to remember the information later. Just for basic functional tasks like medications, use a pill box. Use some kind of organizational system, and that will also help you to stay on top of those things. Write it down, of course. You have a visual then to go along with what you have been told. Engage with the information. Make associations. How does this information relate to what I already know? If I'm trying to remember the name of a person, do they remind me of someone I know? How do I know them? Really think and engage with that so that you can remember it later. The more time you spend with information at the forefront of learning, the more likely you're going to remember it later, especially in Parkinson's. And repetition, repetition, repetition. So I wanted to give you just one example of a technique that you could use. One of the most common complaints that I hear from people is, I forget, the name of a person. I know the person, I recognize them, and I can't remember the name. And it's really embarrassing because I live in the condominium with this person, my neighbor, and I can't think of their name. So just one little trick. There are many different tools for this, but I just want to introduce a couple things. Convert the person's name to some kind of a cue, or visualize the cue and the face together. So I'm going to give you a couple examples here. Imagine there's a man named Bob. Okay, visualize something. Bob. How can I remember the name Bob? Bobbing for apples. Okay, I'm just going to envision this man. Where's Bob? There he is. So envision, and the sillier it is truly, the better you'll remember it later. Or maybe you can imagine him with hair, locks of Bob Marley hair, or maybe hair like Bob Ross. You have to visualize something, and then later when you see Bob, you remember his name. Okay. Here's another one. You may have met this guy in the coffee shop. I don't know. And you can't remember his name, but you're going to try. So you imagine that he has keys hanging from his ears, and you're thinking, okay, Keith is his name, and that will help you to remember. So create some kind of visual cue. This is just a comic, you can read that. So what is your name? Rich? Oh, in your case, Filthy Rich. Just another way to associate, engage with the information. This is a fun one. So there's one option. If you're trying to remember a grocery list, you could just write it down. But this is another way, and this is a nice way to also stimulate your cognitive function. Practice something that will challenge your brain cells, stimulate your brain cells, keep them connected. And if you're doing that and you're exercising, you're really doing awesome things for the brain. Let's imagine your house. So imagine your home. When you first walk up to the door, what does your door look like? And then when you open the door to your house, you imagine the map, so to speak, of your entryway or the first room. What's there? A couch, a table. Let's say in this case, I walk up, there's a doormat. I see a door handle there. When I enter, I'm going to have an entry table, a staircase, if I'm lucky, and a chandelier. And when you walked up to your doormat this morning, there was broccoli spilled all over the doormat, and it was just such a mess. And not only that, there were bananas hanging from my door handle, which was very odd. When I opened the door and walked in, there was cheese spilling from the entry table and chocolate. And what am I going to do about that? How am I going to clean this up? Paper towels. So I'm going to ask you later, what are the 5 items that I need on the way home today to get from the grocery store? And let's just see if you can remember this. All right, I'm going to pivot a bit, talk some about the psychological symptoms that you may experience and also ways to navigate that as well. Now, depression is the most commonly researched, most frequently researched psychological symptom in Parkinson's. with depression, as well as with anxiety and apathy, what's very interesting about these symptoms is they often precede the diagnosis of Parkinson's and the motor symptoms. And individuals with Parkinson's will often say, I experienced depression or panic or some psychological changes years before I was diagnosed, and I had no idea it was associated with the brain changes that were happening in my brain prior, with neurochemical changes and structural changes. In Parkinson's, depression can be a bit difficult to identify because the symptoms, some of the symptoms of depression overlap with the symptoms you may be experiencing simply related to the condition. Appetite change, sleep trouble, concentration difficulty, or there may be an apathy. So I want to talk about apathy. It's a symptom of depression, or can be a symptom of depression, reduced interest, reduced initiative, reduced motivation, but also it can exist as its own syndrome, not necessarily in the presence of depressed mood. That's important to know because a lot of family members may assume that their loved one with Parkinson's is depressed, and they may or may not be. They may be, but the masked face that sometimes comes with Parkinson's can also make it look like the person is really down. With apathy, we like to talk about this and address this and discuss this because apathy and depression really have negative consequences if they're not managed. So if you have reduced initiative, either in behavior, cognition, or emotion, that's how they often present. With behavior, we're talking about difficulty initiating, or not having the self-generated desire, the self-generated initiative for engaging in activities that I used to engage in, or cognitively not pondering ideas as much, or emotionally just seeming a little emotionally more flattened. And so it can be misinterpreted as depression or as laziness. But when they're not discussed, and this is why I say mention this to your doctor too, and possibly there can be treatments for this medically or behaviorally. Faster cognitive decline is what this can be associated with. Poor quality of life, faster physical decline, and increased stress on the care partners. And it makes sense because if you're not initiating your medications, for instance, you just don't get up to take them, then you're not going to be able to treat your symptoms appropriately to slow that progression of the disease, right? To treat the symptoms. If you're not exercising because you don't have the initiative, well, then you're not helping to slow down that decline as well. So it's important, and it can be discussed with a healthcare therapist, or a therapist, or a psychologist, to help you with a goal-setting plan. This is just to show that it gets more common with time, that these symptoms are more prevalent as the disease progresses. And anxiety is common too. So with anxiety, the way it often presents is anxiety either as a generalized worry, anticipatory worry. It may present as the NOS anxiety, the green bar all the way to the right, refers to Parkinson's-specific anxiety because of symptoms. So I don't want to go into a social setting because I'm concerned about slurred speech or falling, those appearing, symptoms that appear. And then psychosis, I mention this because this is also not uncommon in individuals, and it presents in a wide variety of ways. So you may have visual illusions, or what we would call misperceptions, where you misperceive something that is there as something that it's not. So you may see an electrical cord, and you see it as a snake until you get closer and you realize, oh, it's not that at all. Those are visual misperceptions. Now, other people may have hallucinations. And it's more common to have a more mild hallucination in the early stages, if at all, where you may feel that there's some movement in the peripheral vision, or what's called a presence hallucination, where you feel there's somebody present but nobody is there. And then as that progresses, some people will experience more vivid visual hallucinations, And in the people that I have met that have this, most people will say, I can recognize, it takes me a minute, but I can distinguish what's there and what really isn't there. It's not as distressing, but over time it can become more distressing. Now, of course, in dementia with Lewy bodies, this is an early common symptom. Again, not in every person, but in most people with dementia with Lewy bodies, which is a atypical Parkinsonian syndrome and a sister disease, I guess we could say, on the spectrum of this disease. But they experience this early as an early symptom, and that's part of what differentiates that diagnosis. And I will just add on to that yes, it can be related to medication side effect, but also unrelated to medication too, depending on the person. So what I want to say here is, it is, like I said earlier, it's very important to mention it to your doctor. Don't be shy about these symptoms. They're not uncommon. They're pretty common. So, I would say some people feel a little stigma for having psychological symptoms, but it's important to mention because it can affect possibly medications that are selected and treatment planning for you. And there are things that can be done about these things. The other reason to mention this to your doctors. There are other medical issues like thyroid abnormalities that could be causing the symptom and not from the Parkinson's at all. So it's good just to have those things ruled out. Now, for apathy, for those of you who are experiencing this reduced initiative, this reduced motivation, one of the best things that you can do is goal setting. Writing in your calendar and making these activities a habit. If you can think of even just one positive activity that you would like to include in your weeks to come, think about that now and just come up with something. Exercise. Maybe you want to connect more with family members or friends. Perhaps there's something you've been wanting to learn about. Now, you want to make the goal what we call SMART, meaning the goal shouldn't be vague, because the more vague a goal is, the more likely you're not going to achieve it. So if you can make it extremely specific, what type of exercise am I going to do if exercise is your goal? If you just say, I'm going to exercise more, it's extremely vague and doesn't really give anybody a picture of what that's going to look like. If I say, I'm going to get out my stationary bike or go somewhere in my neighborhood or, in your condo association, you may have a gym where I can access a stationary bike, and I'm going to ride it for 15 minutes. That's the measurable piece. So you need to make it measurable. How many minutes will you spend doing the exercise? Or if you're swimming, for instance, how many laps will you do? So make it very clear. It needs to be attainable. If it's too challenging, you're likely going to kind of burn yourself out on that first encounter and decide you don't want to exercise anymore. So we definitely don't want that. But also, if the activity is too easy, that can also be amotivating as well. And it also needs to be relevant. A lot of times, a family member is encouraging the person with Parkinson's to do these activities, and that is helpful, I will say, because that apathy is because of a difficulty with self-generation. If there's some external cueing, that can be helpful. Even if it's on a calendar, some kind of system that's external, that can be helpful. But also, you don't want to be a nag. Nobody wants to be in that position, and a lot of the family members feel they ultimately end up being a nag for these kind of things. So find an activity that is important to you, something that you would want to do, and then make it time-bound. So what days, what times of the week am I going to engage in this? Monday, Wednesday, Friday, at 10 a.m., I'm going to do this stationary bicycling for 15 minutes. Okay, and you can start small, because what's more important than the amount of time is the habit. First, get in the habit. Then over time, increase that amount of exercise by 5 minutes each time, every week, say. Start out just doing 5 minutes each time, just to get in the habit, if that's what it takes for you. So I will just say, the more intense the aerobic exercise, the cardiovascular, if you can get your heart rate up, the more benefits that it will have on your brain health and cognitive health. Now, for those that have depression or anxiety, cognitive behavioral therapy is one of the most empirically supported treatments, and it's effective in Parkinson's, not just in the general population as well. Cognitive behavioral therapy refers to a therapy that addresses cognitions or thoughts or habits of the mind. So in that, in a therapy setting, what we do is we try to help people identify, what are your habits of the mind? Do you tend to make assumptions? Do you tend to jump to conclusions? Do you label yourself in a negative way? Or do you magnify the negative things and kind of minimize your accomplishments? Those are habits of the mind that we try to identify. And those thoughts, those negative thoughts, can perpetuate a negative emotion, of course, and it becomes a cycle. In addition, behavioral activation is key. So identifying enjoyable activities that you can engage in that can boost your mood is also very helpful. Now, for anxiety, also relaxation strategies are very helpful. Learning how to breathe in a way that can calm your heart rate, breathing in, breathing out slowly. Progressive muscle relaxation is where you identify or focus on your muscles starting at the bottom of your feet and working your way up your body all the way to the top of your scalp. Guided imagery is creating a very relaxing place in your mind, whether that's the beach or whether that is in a safe place in your home. Whatever is a safe and relaxing place for you, envision it in detail. You want to incorporate all of your senses. So if you can picture a place that makes you feel relaxed, what does it sound like? What does it smell like? What are what do I see? And then you can take yourself there at a later time in your mind when you need to calm yourself down. And finally, but definitely not least, is mindfulness practice. And this is kind of a cure-all, in my opinion. So with mindfulness practice, you can address mood regulation. So if you tend to get snappy more so now than you used to, very helpful for that. Very helpful for anxiety and stress if you feel overwhelmed. Very helpful for pain management. Very helpful for cognition, specifically attention and executive function. So it helps in many ways. I would encourage you to research this further on your own and to try to find classes near you. You can do it on your own, but it's much better, I would say, in a session with others, because you have some support there and a coach. But it's about being present in the moment, about having self-compassion, about having compassion towards others, which of course I think we all need and could benefit from, and which improves quality of life, which is what is really important. So, who can remember what I need to pick up from the grocery store today? Excellent, excellent. I love it. You see? Thank you.
Dr. Butterfield, thank you so much. Let's give her a round of applause. So we all know how important exercise is and the overall strength in our fight of this disease day in and day out. But sometimes we forget about one of the most important muscles, and that's our voice. And so right now, let's give a very warm welcome to Maestro Joseph Calkins. Where are you, Maestro? Here he comes. He is going to come and talk with us a little bit about our off-key chorale program and do a vocal stretch. So welcome, Maestro.
Very good. All right. Well, good afternoon. Good morning, everybody. How you doing? All right. So you may say to yourself, but Joe, I'm not a singer. But you know what? All of us have a voice. And when you sing a little bit and the person next to you sings a little bit and the person next to them, guess what? All of a sudden we have a full room singing, and you'll say to yourself, oh my God, we are singers. So I want to kind of prove that out. We have a couple of our Key Chorale volunteers. We've been doing a group called Off Key Chorale with Neuro Challenge for Parkinson since 2012, and it is one of the most fun experiences you can have. A lot of the things you just heard about, we do every time. So we're going to prove it. We're going to burn a calorie. Are you ready to do a little mini workout? All right, so we're going to do our mini workout. Our mini workout is going to be this. So everybody grab an imaginary rung on a ladder. Everyone see it? Very good. I'm going to move myself here. I need a little more room here. There we go. All right, so here we go. And we're climbing the ladder. Very nice. So the higher you reach, the better the stretch. Beautiful. You're doing great. You look awesome. Now, let's row the boat and see if we can burn another calorie. So grab your oars in front of you, and then, oh, here we go. Very nice. This is the boat going to nowhere. But we're making great time, right? All right, and if you fall out of the boat, you can swim. So let's do a little swimming. Very nice. And lastly, we're going to lift the barbell. Are you ready? Here we go. Oh, very nice. See, you easily already burned 2 calories. And the nice thing about it is, so we do a lot of breathing. So I want to do a little bit, we just talked about breathing and how important that is. It's essential to singing, but also to projecting your voice. So we're going to do a little exercise. We're going to take a half a breath in. We're going to blow all the air out. We're going to suspend for a second and then take a deep breath. And this is just to connect with that breath. So everybody take a half a breath in and blow all the air out till you're completely out of air. And then we're going to suspend for an uncomfortably long amount of time. And then take a deep breath and let it go. If you want to do the gestures with me one more time, how do you do? Half a breath in and blow all the air out till you're completely out of air. Beautiful. And we'll suspend for a second. Deep breath and out. And so breathing is the most important thing we can do. This is a little tricky to do, but you might have to kind of go 3/4. But we're going to kind of use our arms and breathe in and breathe out. You'll look a little bit like an eagle. All right, let's try it. Here we go. In on 4 counts. 1, 2, 3, 4, and out. 1, 2, 3, 4. Let's go to 5. 1, 2, 3, 4, 5, and out. 1, 2, 3, 4, 5. Let's go to 6. 1, 2, 3, 4, 5, 6. 2, 3, 4, 5, 6. Now we're going to sing a song. This is a big hit from 1910. Hopefully you'll see these lyrics. It's "Let Me Call You Sweetheart." Does anyone remember that dumb song? A couple. All right. So I'm going to sing half of it, and you can sing it back to me. Here's the first part. Let me call you sweetheart, I'm in love with you. Let me hear you whisper that you love me too. Try it with me. This is the first stanza, and let me call you sweetheart, I'm in love with you. Let me hear you whisper. Let me hear you whisper that you love me. And it says right on the music, on Let Me Call You Sweetheart, it says bustigato. Bustigato is an Italian term for sing as loud as you possibly can. All right, let's try that again. Ready, go. Let me call you sweetheart, I'm in love with you. Let me hear you. Let me hear you whisper that you love me. Now there's a payoff. You say, why are we singing this dumb song? There's a payoff. It's coming. We have to learn the next verse, which is, keep the love light glowing in your eyes so true. Let me call you sweetheart, I'm in love with you. Let's do the second half. Keep the love light glowing, and keep the love light glowing in your eyes. Oh, true. Remember, bustigato. Let me call you sweetheart, I'm in love with you. Let's do that one more time. Ready? From keep the love light, and keep the love light glowing in your eyes so true. You're sounding good. Let me call you sweetheart, I'm in love with you. So let's do the whole thing, and then we have a game we're going to do, which is going to be quite fun, I promise. Here we go. Ready? Let me call you sweetheart, and let me call you sweetheart, I'm in love with you. Let me hear you with. Let me whisper that you love me to keep the love light glowing. Keep the love light glowing in your eyes so true. Let me call you sweetheart. I'm in love with. See, we already have a choir. This is pretty good. So, nicely done. So, here's what I would suggest. If you thought that was fun or you hated it, either way, come and see us at the booth. We have this group called Off-Key Chorale, which is an incredible experience. It's fun. It's the therapeutic benefits of singing. Every person who comes and does our 8 weeks, by the 8th week, we can hear them. They're talking louder. They're applying all the things that you do for singing to their regular lives, and it makes a big difference, and it's just absolutely fun, and it's way more fun than therapy. I guarantee you. All right, so here's what we're going to do. So you're looking at these words. We're going to sing the song again, but you cannot sing any of the pronouns. So you can't do me and you and I, but we do everything else. Sounds easy, right? But the best thing is, the louder you sing, when you make a mistake, we'll all laugh at each other. All right, so are you ready? So no pronouns. Good luck. God bless. Here we go. Ready? And let call sweetheart in love with. Let me whisper that to. Oh, very good. Keep the love light glowing in. So true. Big finish. Let call. Perfect. Excellent. You guys are awesome singers. Thank you for playing along today. Come and see us at the booth. We'll tell you more about Off-Key Chorale, and have a great afternoon and a great morning. Thank you.
Maestro Joe, thank you so much. Wasn't that fun? You all did a great job with that. His little game that he played. All right, so next up, we have with us Dr. Darlene Lobel, board-certified movement disorder specialist and neurologist, presenting on novel treatments for movement disorders. I had the opportunity to meet Dr. Lobel last night. We had a lovely conversation, and it's my honor to welcome her to the Expo stage.
Well, hello, everyone. I'm Dr. Darlene Lobel. I'm a neurosurgeon. I practice at Manatee Memorial just across the river and Blake Hospital just on the west side of Bradenton. So I had two passions when I was a little girl. One of those was healing, as you might imagine, but the other was music. And when you couldn't find me bandaging up our cats, whether they needed it or not, I was at the piano working on beautiful Chopin or Beethoven compositions. And so I want to share both of my passions with you today. So if we can play this beautiful sonata by Beethoven, I want to encourage you to close your eyes and think about one of your passions while you're listening to the music here. You didn't know you were coming to a music concert today, did you? Let me tell you something very interesting. I used to think these two passions had nothing to do with each other till I started studying. Do you know what you've just done in the last 30 seconds listening to that? In combination, actually, with the vocal exercises. I didn't plan this way, but they could not have done a better job than putting this right before my talk. You have literally just changed the rhythm of your brain in the last 30 seconds. With Parkinson's disease, one of the problems is your brain cells don't talk to each other at a regular rate and rhythm. That's why we put in deep brain stimulators, right? To help them come into rhythm. I did this amazing study up at the Cleveland Clinic. We do the DBS surgery with patients awake, and we played music for them, one of the pieces that you just heard, we played silence for some other folks, and then we played another rhythmic piece of music for others. When we were recording the sounds of the brain cells with either no music or with the rhythmic music, we heard irregular patterns as we expected with Parkinson's. But when we played that piece that I just played you, the brain came in to rhythm and it almost mimicked DBS. Is that amazing? I want to tell you something. This is a premise for this entire talk today, and really for this session. Your brain has the capability and is literally designed to heal itself. Your brain creates new brain cells every single day. Do you know this? You create 4,000 brain cells every day that we know of. From the day you're born, well, there's many more from the day you're born, but until the day you die. We used to think when I went to medical school, your brain stopped growing at the age of 20. Not true. You are designed for growth. The brain has an amazing ability to rewire itself around injury. Individuals that have a stroke, you know what? The adjacent tissue takes over the function of the damaged tissue so you can regain the ability to move, to speak. Your brain is the most amazing organ in the world. Today, I'm here to give you some information, of course. We're here to educate. More than that, I hope that you come out of this talk and out of this day inspired. I want you to have hope to hold on to. And I want you to actually experience transformation. You've already experienced transformation just by showing up, by listening to this music, participating in the vocal exercises, and you've got more transformation coming. Now, I'm here to talk to you, of course, about novel therapies for Parkinson's disease and other movement disorders, and I am going to tell you about deep brain stimulation, and I'm going to touch on a couple of other therapies as well. But I want you to consider that there may be a novel way to look at other therapies that have been around for quite a long time. Dr. Butterfeld mentioned a few of these, and you're going to get some more lectures on these later today. Your diet's actually a therapy, okay? Movement is a therapy. Visualization, I'm going to go into this. Do you know there's a network of cells in your brain in charge of visualization? It's called the mirror neuron network. Like you look at yourself in the mirror, neurons are brain cells. There's a network of cells that have amazing capability to help you. As doctors, as surgeons, as scientists, we're always looking at the root cause of something, right? We want to fix the root cause. We have very well identified what are the chemical changes, what are the electrical changes that lead to symptoms of Parkinson's disease and other movement disorders. Now, traditional medicine, we as doctors, surgeons, and scientists provide to you medications. We provide to you surgical procedures. We provide to you other therapies that counteract those changes. I would suggest to you that that is a very small way that you can heal. I would instead suggest to you a novel approach that we can and have identified things that you can modify in your lifestyle, activities that contribute to, that stabilize, and that reverse those changes. You know, one of the things I see about patients with Parkinson's disease over these last 15 or so years in practice, it's all about reaction. You get a diagnosis, you react to it, right? That's not how we're designed. We are actually designed to be proactive, and we are giving you an opportunity to participate in that today so that you can leave here with a greater degree of empowerment than you have had before. Now, we know Parkinson's symptoms start when we lose about 80% of our dopamine-producing cells, right, in the brain and the substantia nigra. However, we also know by studying dopamine in other areas that lack of movement decreases dopamine additionally. And you may say, well, Dr. Lobel, of course, I can't move. I have difficulty moving, so how am I supposed to fix that? Well, guess what? I have a solution for you in just a moment, all right? Chaos. Did you know this? This is so interesting. Chaos produces adrenaline. You may have heard of this, right? When we're in a state of stress, your brain releases adrenaline, so gives blood, increased blood to your heart, to your lungs, to your muscles. Do you know what it does right after it releases that adrenaline? It sends a signal to begin to replace the adrenaline, okay? Now, if you have a healthy diet, nutrition, you've given your body good food, it has building blocks to rebuild that adrenaline. But do you know what happens if you don't? Guess what it breaks down? It breaks down dopamine. It breaks down serotonin, and it breaks down oxytocin for its parts so it can recreate adrenaline so you'll be ready the next time you're stressed. Chaos in your life has a major neurochemical impact on you. So we know, and I'm not going to go too much into detail, you're going to get a wonderful lecture later today on nutrition. Your B vitamins increase dopamine. Mediterranean diet, high octanoic acid diet, increase dopamine. Copaiba, cannabis, you're going to hear about, increase dopamine. You're in control of that. Tai Chi. There's been clinical studies on Tai Chi that show improvement in motor symptoms with Parkinson's disease. Even if you do Tai Chi in your chair, it helps. But what about those people that don't feel like they can move at all? Maybe you experience a lot of freezing. What do you do? So this mirror neuron network that I was mentioning to you a few minutes ago, here's what it does. This has been studied since 1988. It was discovered. Your brain cannot tell the difference between whether you are actually moving your arm or you are envisioning your arm moving. It activates the same cells in the mirror neuron network and the same pathways, and guess what? You get a dopamine release just by closing your eyes and imagining your arm move. I did a 1.5 years of research on this topic in Grenoble, France, working with Benabid, and we were able to capture electrical activity in the brain that was powerful enough to light a light bulb, to run a machine, just with the intention to move, okay? So everybody can take time, a little time every day, even if you don't feel like getting up, even if you don't feel like taking a walk that day. And you can close your eyes and walk yourself through it. You're gonna hear me use the word empowerment quite a bit today, and I love that it's actually part of the slogan here for the Expo. I was so excited to see all of the speakers coming through here. And I, as a neuroscientist, said, hey, you know what? This does a lot of great things for the brain. Those vocal exercises you just did, guess what? Release serotonin, which you know what that does? It lowers your stress, lowers your chaos. See? You're already having change and transformation. You're going to hear a talk later today about cannabis. Does many things, but also directly increases the impact of dopamine in the brain. You're going to learn about nutrition and Parkinson's disease, which is those building blocks so your brain doesn't have to break down more dopamine. You had a great talk from Dr. Butterfeld. She gave you all kinds of wonderful strategies, right? Do you know what that did? Increased your brain connectivity. You know, there's more than one pathway in your brain related to Parkinson's. One causes symptoms more of tremor, those positive symptoms, and another pathway causes more the negative symptoms, so the slowness and stiffness of movement. When you do these exercises, you get to dictate to your brain, which pathway gets activated, okay? It's very powerful how this works. You're gonna hear another great talk this afternoon about a device that will help to not only improve symptoms of tremor and other symptoms, but it will also change the energy state of the brain to a flow state, okay? That gets you out of being stuck and move forward. We're talking about caregivers later today and patient stories, telling your story. You know what that releases? Oxytocin. Oxytocin is a great chemical, does many things, directly reduces levodopa-induced dyskinesias, okay? You're getting a neurochemical makeover today, an energetic makeover today by being here. So we're so glad you're here. Mindset is so pivotal to the healing process. This was a study I did at Cleveland Clinic a few years ago. We measured tremor scores in patients before and after DBS. I did that. And then I would ask my patients, how much do you think your tremor improved? Sometimes I would see, well, tremor went from severe to mild, but the patient would say, nope, my tremor's still severe. We said, well, that's interesting. How do other clinicians look? They agreed with me. The patient didn't agree. We were able to map that to whether they had depression or anxiety. So when Dr. Butterfield is talking about treating these other conditions, it is very, very important. I wrote an article a couple years ago on US News and World Report about rewiring your brain for healing. I encourage you to go take a look at that article. I'm not going to go into it today because it's in depth, but it's going to give you some really powerful strategies to begin to have increased empowerment. I'm going to give you 3 strategies here, and then we're going to talk about DBS. First one is this. You've been told a lot of things about what is possible with Parkinson's disease, what is likely to happen. I'm going to invite you to make a choice to say, you know what? I don't agree with what other limits someone else has set. As soon as you do that, if you ask your brain the question, what if? What if that's wrong? What if? Dr. Butterfield talked about how the data changed, right? We don't know everything, but you have control. Second thing is this. I want you to recognize your identity is not rooted in Parkinson's disease, okay? When you say the words, I am a Parkinson's disease patient, do you know what that does? That activates your identity centers in your brain, in the medial prefrontal cortex, that are in the same area as your goal-directed centers. That means you've now given your brain a goal for the day of what? To be a Parkinson's patient. Be careful what you say after the words, I am. You are so much more than whatever condition you are dealing with. You are created from your values, from your passions. And thirdly, I want you to imagine your life beyond healing. When you closed your eyes a few minutes ago and thought about one of your passions, okay, wouldn't you love to do that again? Set that as your goal, and your brain will work with you. It'll actually bypass what you think you need in order to get there, and it will help you. All right. Let's talk a little bit about brain stimulation as we finish up. Those of you that haven't heard of this, this is placing tiny electrodes deep inside the brain. Basically, is a brain pacemaker, just like a heart pacemaker. When the heart doesn't beat at a normal rate and rhythm, we put in a cardiac pacemaker. With DBS, it's like a brain pacemaker. It delivers electrical pulses to the brain to reduce tremor by about 90%, stiffness and slowness of movement by about 60 to 70%, and cuts medications. We don't think that everybody is a good candidate for DBS. In fact, we have a whole team put together in order to do these evaluations. But when the medicines you're taking are causing more side effects than they are helping, we start to look at this. We do a thorough physical exam, we do lab studies, we look at the MRI of your brain, we see how much you improve when you take dopaminergic medicines, all right? And importantly, I want to be sure that you're healthy enough to undergo deep brain stimulation surgery. It's an awake brain surgery. Don't let that scare you. You're asleep for the drilling of the hole, okay? But you get to actually wake up and participate, which is the reason I decided to start doing this surgery so much. Because the first time I saw a lady who had very disabling tremor not be able to write her name. She just wanted to write letters to her friends, right? And she couldn't write her name legibly. And in the OR, we had her do that, and it didn't look good. And then we put on the stimulator, and she wrote her name beautifully. And she started to cry because she knew that her life was changing. I want to show you these videos here. We'll start with what it looks like with DBS turned off. So if we can play the left video.
She was like, I'm hoping I get the right date. I was in this fear of like, oh my gosh.
Well, perhaps.
I'm home with God here. Oh, but my GPS said you take me from my sister's house 55 minutes.
Can we get the videos to play, please?
Yeah.
And then I saw my ETA getting.
And the doors. Oh, it's no problem, but I'm like,
There we go. Okay, so you can see typical shuffling gait with Parkinson's disease here. No arm swing. And then after, with the DBS on, you're gonna see a remarkable change. Same patient, DBS turned on, you're actually gonna see him getting up out of a chair easily. Look at that. Look at that. And then you're gonna see him start walking down the hall.
right.
Ready, Karen?
I'm ready. Remarkable. Remarkable. And this is typical. This is a typical response to deep brain stimulation. Transformative. Okay, thank you. All right. Missed a slide. You can probably take a screenshot of this. I'm not going to go through this in too much detail, but this shows the long-term efficacy with deep brain stimulation. Okay, this is after 15 years. You still experience 75% decrease in dyskinesias, 50 to 70% improvement in stiffness of slowness of movement. Get your medications cut in half. It is a wonderful, wonderful therapy. I do it a little differently than you may have seen before. You may have seen that big head frame that's kind of scary to patients. Well, it was kind of scary to me too. So I said, there's got to be a better way. I found this wonderful company. I've been doing DBS this way exclusively since 2008. You actually have a 3D printed mini frame that we put on your head that shows us where to cut, where to put the leads, and you can have a souvenir to take home after the surgery. You have control of the programming yourself. With some companies, you can actually put the controller on your iPhone if you have an Apple device. Isn't that amazing? Turn your stimulator up, turn it down. This is our team. We work with general neurologists, family medicine doctors, movement disorder specialists, physical therapists, occupational therapists, neuropsychologist. We talk about every single patient. So you have a lot of visits going for DBS. The other thing I want to say is this, because sometimes people think when they get to me, because I'm the surgeon, oh, that means she's going to want to cut on me. No. Many patients come to me for information, and we go through in detail what the procedure looks like. So don't be afraid to come talk to me or another neurosurgeon to do this procedure. It's about information, and we make the decision together. Remember, this is about empowering you. A couple non-invasive options if you're not a surgical candidate, so you can't tolerate the actual anesthesia with surgery. We can do two different procedures. One is a gamma knife pallidotomy, and the other is focused ultrasound. And those have some very good results. They do have some higher side effect profiles than deep brain stimulation. And importantly, this does create a permanent lesion in the brain, as opposed to DBS, which is a modulation therapy. So DBS can be removed at any time, doesn't do any direct damage to the brain, whereas this basically makes a tiny little hole in those pathways that can lead to tremor and your other symptoms. So my last thing that I want to say today is to empower you. What are your next steps? And you don't have to answer that after this talk. Answer it after your day today. What information resonated with you the most? You're going to get a lot of information today, but there's a reason each one of you is here, right? Pay attention to that. What inspired you the most? What gave you the most hope? What transformation are you going to choose to focus on? That is where you're going to see the beginning of a new life that you're looking for. Thank you very much.
Thank you so much, Dr. Lobel. Let's give her one more round of applause. That was an amazing presentation full of hope and positivity, and we really appreciate that. Folks, I want to take a brief moment because I saw our founder, Dr. Dean Sutherland, in the audience today, so I would just like to give him a big shout out as well, if you don't mind. Dr. Sutherland and his late wife, Doreen, founded Neuro Challenge 16 years ago, and who would know that we would get to this point where we serve around 3,000 people every year in a 6-county region in Florida, which we think is incredible, and it's all due to the generous support that we get from our sponsors and our donors and people like you who show up. So thank you very, very much for that. And you know I have to do it. I have to ask for money. So if you are enjoying what's going on today and the fact that we're able to bring this to everyone free of charge, if you would be so moved to give us a donation, there are multiple ways you can do that. There is a QR code in your program. There is our table back in the back. Anyway, and we would be very appreciative if you are so moved to give us a donation. Thank you very much. Now it is time for a little break. We have our first 35-minute break. All the exhibitors are officially open, including our interactive demonstration, so please don't miss that. It's all behind the curtain in the exhibitor area. Please be sure to stop by our photo booth. We have some great costumes. We'd love you to post and tag those photos and have a little souvenir for the day. And for everyone who's joining us at home, we will see you back on the live stream live at 11:45 a.m. Eastern Time. Everyone take a break, grab a snack, join us back here in about 30 minutes.
tumbling down in the city that we love. Great clouds roll over the hills, bringing darkness from above. But if you close your eyes, does it almost feel like nothing changed at all? And if you close your eyes, does it almost feel like you've been here before? How am I gonna be an optimist about this? How am I gonna be an optimist about this? Oh, where do we begin? The rubble or our sins? Oh, where do we begin? The rubble or our sins? And the walls kept tumbling down in the city that we love. Great clouds roll over the hills, bringing darkness from above. But if you close your eyes, does it almost feel like nothing changed at all? And if you close your eyes, does it almost feel like you've been here before? Oh, how am I gonna be an optimist about this? How am I gonna be an optimist about this? If you close your eyes, does it almost feel like nothing changed at all? sunshine when she's gone. It's not warm when she's away. Ain't no sunshine when she's gone, and she's always gone too long. Anytime she goes away, wonder this time where she's gone. Wonder if she's gonna stay. Ain't no sunshine when she's gone, and this house just ain't no home. Anytime she goes away. And I know, 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 I know. Hey, I ought to leave the young thing alone, but ain't no sunshine when she's gone. Ain't no sunshine when she's gone. Only darkness every day. Ain't no sunshine when she's gone, and this house just ain't no home. Anytime she goes away. Anytime she goes away. Anytime she goes away. Anytime she goes away.
you take my call when I start to crack? Would you rescue me? Would you rescue me? Would you rescue me when I'm by myself? When I need your love, if I need your help, would you rescue me? Would you rescue me? We don't don't talk much, not anymore. Broken bottles and slamming doors, but we still care about each other. Say we care about each other. I know life took us far away, but I still dream about the good old days when we took care of each other. We were living for each other. But I start to wonder if I'm slipping under. Would you rescue me? Would you get my back? Would you take my call when I start to crack? Would you rescue me? Would you rescue me? Would you rescue me when I'm by myself? When I need your love, if I need your help, would you rescue me? Would you rescue me? Would you rescue me? Would you get my back? Would you take my call when I start to crack? Would you rescue me? Would you rescue me? Would you rescue me when I'm by myself? When I need your love, if I need your help, would you rescue me? Would you rescue me? Yeah, I miss all the times we had. Can't forget what you can't get back, and you can't find it in another. Man, time, it ain't your lover. I don't care what you thought before. I'll be there anytime you call. Don't you ever call another. No need to call another. And I start to wonder if I'm slipping under. Would you rescue me? Would you get my back? Would you take my call when I start to crack? Would you rescue me? Would you rescue me? Would you rescue me when I'm by myself? When I need your love, if I need your help, would you rescue me? Would you rescue me? Would you rescue me? Oh, rescue me. Would you rescue me? Would you rescue Would you rescue me? Would you get my back? Would you take my call when I start to crack? Would you rescue me? Would you rescue me? Would you rescue me when I'm by myself? When I need your love, if I need your help, would you rescue me? Would you rescue me?
Please make your way back to your seats. The program will resume in 5 minutes. Please make your way to your seats. The program will resume shortly.
We get it almost every night, and when that moon gets so big and bright, it's supernatural delight. Everybody was dancing in the moonlight. Everybody here is out of sight. They don't bark and they don't bite. They keep things loose, they keep things alive. Everybody was dancing in the moonlight. Dancing in the moonlight. Everybody's feeling warm and bright. It's such a fine and natural sight. Everybody's dancing in the moonlight. We like our fun and we never fight. You can't dance and stay uptight. It's supernatural delight. Everybody was dancing in the moonlight. Dancing in the moonlight.
Please make your way back to your seats. The program will resume shortly.
Everybody here is out of sight. They don't bark and they don't bite. They keep things loose, they keep things alive. Everybody was dancing in the moonlight. Everybody's dancing in the moonlight. Everybody's feeling warm and bright. It's such a fine and natural sight. Everybody's dancing in the moonlight. Everybody's dancing in the moonlight. Everybody's feeling warm and bright. It's such a fine and natural sight. Everybody's dancing in the moonlight. Everybody's dancing in the moonlight. Everybody's feeling warm and bright. It's such a fine and natural sight. Everybody's dancing in the moonlight. Everybody's dancing in the moonlight. Everybody's feeling warm and bright. It's such a fine and natural sight.
Maybe I'm foolish, maybe I'm blind, thinking I can see through this and see what's behind. Got no way to prove it, so maybe I'm lying. But I'm only human after all. I'm only human after all. Don't put your blame on me.
Please find your seats. Our program is going to begin very soon.
Take a look in the mirror, what do you see? Do you see it clearer, or are you deceived in what you believe? 'Cause I'm only human after all, and you're only human after all. Don't put the blame on me. Don't put your blame on me.
Welcome back, everybody. I know some of you are still making your way to your seats in the main hall, so please continue to filter in. I wanted to recently I just wanted to mention that recently we launched the Neuro Challenge Network. Some of you may be aware of the Neuro Challenge Network. And the network is designed to offer expert Parkinson's education and training to non-specialist healthcare providers. In other words, it's Neuro Challenge trying to help the medical community do a better job of treating the Parkinson's community. And we are thrilled to announce that we have our first set of Parkinson's trained partners. That is Care Patrol of Sarasota, Sunway's Senior Living Concierge, and Youthful Aging Home Health Care. These organizations have gone through and completed our training, so you know when you work with them that you can be confident their employees have been trained specifically to work with the Parkinson's community. And we applaud them for taking this step, and we are very grateful for their partnership. And next, we are going to hear from one of these Parkinson's trained partners, Care Patrol of Sarasota. CEO Wendy Rickenbach is here to present something I know that many of us can relate to, which is care is expensive. My loved one wants to stay home forever. So please help me welcome to the stage Wendy Rickenbach Barclay.
All right, you guys can do better than that. That was not very welcoming, I'm just saying. Okay, yeah, come on. All right, there we go. All right, where are my caregivers? Give me some hands. I don't care if you're caring for someone with Parkinson's, but anybody in this room that is caregiving. I know there has to be more hands. All right, how many of you want to keep your loved one home forever, and how many of those loved ones want to be home forever? Is that everybody in this room? All right, have any of you ever looked at how expensive care costs? Has anybody done that yet? Many of us? All right, I do not have a lot of time. And I'm going to tell you that I talk very quickly. I spent 20 years on Wall Street prior to starting Care Patrol 10 years ago, and it's an occupational hazard. However, if I talk really fast and you don't catch something I say, we do have a booth in back. All right, so I want to jump right in. How expensive is it for caregiving? Oh, we don't need to know about my bio. I'm really amazing. Just ask me. You can Google me. Don't ask my husband, he may have a different opinion of that. All right, so all my caregivers, you guys need a pay raise. You wanna hear why? I've got this wonderful PowerPoint right here. I want to have a 24/7 caregiver in your home will run you a little over $262,000 a year. So let's break that down. Let's break down where those dollars come from. I'm assuming if you're at home, somebody's got to cook the food, prep the food, shop for the food, make sure that it gets cleaned up after every meal. So if you wanted a full-time chef doing that job, it's about $35,000 a year. All right, y'all feeling me so far? All right, what about a live-in housekeeper? Any of you guys doing some laundry, dusting, cleaning? Maybe somebody's got some incontinence. We're going to clean up a little bit of that, change those sheets more frequently than we'd really like to. Okay, so for a full-time live-in housekeeper to do all of that, that runs about $45,000 a year. Yep, you're hearing me. All right, now then we've got some administrative stuff that happens in your household. I'm sure somebody's got to pay the bills. They got to make a lot of phone calls to doctors. Y'all got Parkinson's, so you're talking to doctors somewhere. Then making sure those medical bills get paid, right? And you're following up on the bills and what they're going to pay for and all those things. So if you had a full-time administrative assistant, the average going rate's about $35,000. And then just that annual cost of caregiving. So when you add all those up, that's about almost $378,000 a year. Who wants a pay raise? Anybody? Yeah, let's do it. Let's all get a pay raise. Okay, that would be super fun. All right, so I want to figure out ways to help you guys support yourselves on your journey, whatever that journey is. It might be Parkinson's. It might just be we're getting a little older. Maybe we're aging. Maybe we have other things happening. Parkinson's isn't the only thing that happens as we age, right? Maybe we have some dementia happening, some forgetfulness that's going to potentially progress, right? So I want to help figure out ways to go on this journey with you and educate you a little bit about how much stuff costs so we can figure it out before you need it. Would that be great? You guys probably won't do it because I stand at conferences like this all the time and nobody calls me till they're in a hospital bed and they're in a crisis because they're going to be at home forever and not get any help. And I am all for that. I want you to be at home. But what I find a lot of times is I've got two seniors right? One with Parkinson's, one with dementia, or one just aging. And I'm just going to go the average age between 77 and 87. Anybody in this room meet that criteria? Do not raise your hand. Right? Okay. So we got folks that are aging. And typically what I find is I have one person that's physically better, maybe one person that's cognitively better, or I've got two people that are just helping each other limp along. Does that sound like anybody in this room? Right? So we need to figure it out before you really need it. And then when I ask people, I'm like, are you guys, you got all your paperwork in order? They're like, oh yeah, we're great. 95% of the time, that's not the case. All right. The most expensive thing you can do is to do nothing at all. So today, I've been out in the booth meeting with people, and I had a sweet little lady say that she didn't need any help at all. She didn't need me. She didn't need to talk about it. As she's shuffle walking with her walker, right? And I thought to myself, you need to talk to me. What happens if you fall and break a hip, right? Now, you guys have been studying about this disease, I'm sure. You're probably experts, beyond experts, more than I will ever be. But there's some caregiving facts here, and I was actually just with one of our local neurology doctors at a conference a couple weeks ago, and it was really interesting because he speaks about caregivers being basically in crisis mode, that there's like a trauma and all this other stuff. But here's a fascinating statistic. 70% of the time, everybody say 70%. 70%, that's right, there we go. Something will happen to the caregiver before the person they're caring for. So what happens if something happens to you? What is your plan B? Do we have a plan B, right? What happens if you've got to go to the hospital and have surgery or go to rehab? Who's taking care of your loved one? You think your kids are going to come? They're not going to stay forever. Kids are great. They're going to. I'm a kid. I took care of two parents. I'm great for about a week, two tops. I did not sign up to wipe my parents' butt. I am sorry. And guess what? They don't want me to do it. All right? They don't want me to do it. They want to be independent. They want to make their decisions. They want to be in charge of what happens to them. You guys feel me out there? Anybody feeling me? You guys want to be in charge of what happens? All right, so we got to do something today. Am I at my 15 minutes already? Holy moly. Okay, thank goodness. All right. So what are some challenges that we are facing with this disease? And you guys don't need me. You can read this list. Did you guys know your extreme fall risks? Probably already knew that, didn't you? All right. But I'm going to show. So this is important because when you're falling, your sweet, lovely caregiver's got to help you get up. And it's not pretty sometimes. And if you have fallen and someone's had to help you, I promise you it is not pretty. Now, if you guys meet my husband, I look fairly young, right? Just say yes. Okay. My husband is 6'3" and 2. He's here. He's 260 pounds. So if he falls, I am not picking him up. Let's just call a spade, all right? So I'm going to need to think about as we age what we are going to need because I'm not going to be able to do it. And guess what? I don't want to get hurt trying to get him up off the floor. I don't want you guys to get hurt picking somebody up off the floor. So there's all sorts of things that happen with Parkinson's that are specific to this disease. You got to make sure you get your medicine on time. It's not an hour later, it's not 2 hours later, it's like at that time, right? The impulsivity, and I'm sorry, all my PPP peeps, my people with Parkinson's, y'all think that you have capabilities beyond what sometimes you're really realistically able to do, and I love you for that fierce independence, I do, but sometimes we gotta get real with each other and talk honesty with one another so we can set you up for success, right? And so, somebody just say amen. I feel like I'm at church, okay. I think I heard an amen. That's the first time that's happened. All right, so anyways, what I want to do is I really want to plant some seeds today that we need a plan B. Everybody say we need a plan B. That's right, we need a plan B. Plan A is you're independent forever, you need nothing. Plan B is we might have to tag in some help along the way, okay? And that's what we're trying to accomplish. All right, I want to talk about some let's talk about all the care options real quickly. And let's just drill down some of these costs, okay? And you guys are going to just look at me like, oh, that's way too expensive. We can't afford it. I can't afford that. I only get $1,800 a month Social Security. I can't afford that. Well, I'm going to teach you something that I learned a long time ago. Your budget is not your care budget. That's your income. It's not your budget for care. So we might have to tag some people in to help us figure out what is a care budget. Not what our monthly income is. You know what that is. You see it every month hit your bank account. I want to talk what is your care budget. So I broke down some really, really basic numbers for you guys today. All right? The average cost of in-home care, and there's about 126 of them serving our area. And by the way, you can go to any city across America. It's probably about the same. But the average cost of care is about $35 to $38 an hour. And most of them like 4-hour minimums. Now, I'm not saying you can't go somewhere and get an hour here, an hour there, but you're going to pay a premium, right? But let's just go with the averages, right? I just want averages. All right, so for 4 hours a day in your home, all right, that'll run you about $140 a day times a full year. That's about $49,280 a year. That's for a minimum amount of assistance in your home on a daily basis. And let's just say you bump it up. I get a lot of people say, oh, I only need somebody during the day. They're sleeping at night. Okay. So let's just look at 12 hours a day. I got some numbers up here so you guys can take a look at how much it costs for 12 hours a day. All right? Now, have any of you ever heard of adult day programs? Man, I am on fire for some adult day programs. You want to know why? They're fun, they're social, they have full-time care staff. They're also the cheapest care you can get anywhere in town. And if you live in Sarasota County and Manatee County, you are blessed beyond measure. You want to know why? We are one of the most innovative cities anywhere. We have got adult day programs popping up everywhere with full-time nurses and care staff and support services in those buildings. And I'm just going to tell you at 100, and I just did some averages there, about $145 a day for 8 or 9 hours a day, you know. That's like 8 or 9 hours. Hello, I just told you it's 4 hours at home for $140, right? And you're getting food and programming, you're getting all kinds of stuff. So I think adult day is a beautiful, beautiful way to stay at home longer and get some support and care and mobility that you're going to need to fight this thing and stay home longer, right? Which is what y'all said, you want to be independent forever. So we're going to do it. And I've got to find ways to help you do it. The last thing is assisted living. Now, I don't like to say assisted living. I think it sounds old. When I say assisted living, some of you might be hearing nursing home. It is not. It is really independent living, your own apartment, with on-site assistance, right? That sounds much better, right? Independent apartment, on-site assistance. I like the sound of that a whole lot better. All right, so that's an option, and I just got the average out there for you guys. About 12 months at an average cost of $5,500 is about $66,000 a year. Everybody get their pictures of this slide? I'm gonna move it on. I got about 1 minute left. You good? Okay. All right, that's it. We are good to go. I'll leave it up for you. All right, so we don't have time to talk about all these things in detail. And guess what? Every one of your situations are different from the person sitting next to you. Right? One of the things that I brought with me from my career on Wall Street is where we start, typically is kind of the same. Where we end is sometimes kind of the same. But how we get there is always going to be different because your personal journey is different, your financial circumstances are different, your disease progression is different. All of these things, your wishes and personal lifestyle choices are different. So where we start may be the same, where we end may be the same, but how we get there is different. So I hope that you guys will grab a few of these nuggets, that you will think about what is your plan B, and let's put that together today while you're able to participate in that. Because the worst place to make decisions from is that hospital or rehab bed. You guys, I'm out of time. I thank you. If we can be of service, we do have a booth in the back. Come see us. We'll give you all this information. And thank you for your time. And thank you to the Neuro Challenge team.
Thank you, Wendy. And I think she gets the award for energy, right? Is that true? Thank you, Wendy. We appreciate it. Everyone, it's time for lunch. Please stay in your seats because we are going to bring lunch to you. And the way this works is our volunteers will begin distributing first the vegetarian meal. So I need everyone who ordered a vegetarian meal to please raise your hand and keep it up so we can see it. Are there vegetarians out there? Vegetarian meals. Anyone who ordered a vegetarian meal, please raise your hand. Keep those hands up. What's going to happen is, once all those vegetarian meals are distributed, our volunteers are going to distribute the rest of the non-vegetarian meals to everyone else. And while they're doing that, can I get a great round of applause for our amazing volunteers? Folks, we could not stay on without these volunteers, and they are donating their Saturday to be here with you and in support of you. So my hat is off to all the volunteers, everyone in a bright orange shirt. You are amazing. So as soon as you receive your lunch, please feel free to begin eating. We are going to consider this a working lunch, so go right ahead as soon as you get it. One last thing I'd like to remind everybody about, if you haven't had a chance yet to look through your Expo program, there is a ton of great information in there. Today's agenda, speaker bios, the topics they're presenting on, information about our many exhibitors and sponsors, and of course, a big thank you to all of our sponsors again for being here today. Everyone who had a veggie meal, did you receive it? If not, please raise your hand high. I think we're good on the vegetarian. Water will be coming around as well, so please be patient. They're working the fastest as they can here, distributing lunches and waters. This is our 7th time. It's a pretty well-oiled machine, and I think it's pretty awesome that you get to have lunch right there in your seat. All right, everyone, please, as I said, enjoy your lunch as you receive it, and right now I'm going to bring Jennifer Bittner, our CEO, back to the stage.
This looks good. Everybody's getting lunches, right? Yeah? All right. So, the word has spread about how fantastic the Expo is this year because the media showed up and wanted to interview and take pictures. So, yay, guys! Congratulations! Exactly. Thank you to ABC7 and SNN for coming out and doing some interviews and taking some photos and covering the Expo, letting everybody along the Suncoast know how fantastic today is. All right, how are we doing, volunteers? We doing good? Lunch coming around? All right. So, at this time, I'd like to give a big shout out to some very, very important people that made today possible. And that is the staff at the Neuro Challenge Foundation. So they're all working hard out here right now, but let's give a big round of applause, if you can with your lunch in your laps, I know, to Tracy, April, Danita, Diane, and Leslie. A very hard-working group of ladies who have done a fantastic job in putting today together. So thank you, ladies. You know how much I appreciate you. There's also another group of folks that I would like to say thank you to and to give a shout out to, and that is our Medical Advisory Committee. And so we have a group of trained professionals, doctors. Some of them have been on the stage today. They're here in the crowd with us, and these folks help us put together things like the resource guide that you have today. So let's give a round of applause for all the folks of the Medical Advisory Committee. And Kathy Musto, if she is still here, Kathy is helping spearhead this and get these fine individuals back together again. So thank you to all of them and how you contribute to the success of the Neuro Challenge Foundation. So let's give, as we're waiting on lunch to keep coming around, we're doing good here. Want to give another shout out to all of our sponsors. So when you have time, they're all listed in your program book. I know you've been out visiting with them, but please make sure to say thank you to them for all their support because, again, we're able to offer all of our programs free of charge thanks to their very generous support. And how about the demos? Did you guys have fun with the demos? Did you check some things out? And how about Maestro Joe and Off Key Corral? Wasn't that fantastic? We love Maestro Joe. Okay, so next question. Have you had a chance to meet someone new with Parkinson's today? We know how very important it is for you to find that right support group or peer in the Parkinson's community. And so that's why the Neuro Challenge Foundation created our mentorship program called the Parkinson's Connect. You can read more about this when you have time and not a lunch in your lap on page 25 of your Expo program. And if you're wondering about the mentors, so they're thoroughly trained and selected because they have been on their own Parkinson's journey, and they now feel equipped to be able to give back to others. And we have a couple of our mentors here with us today. Drew and Roger, I don't know where you are in the crowd, but if you're out there, give us a wave. Thank you to Drew. I see, there we go. There's Roger over here, and there's Drew right here in the front. Thank you both. And Carolina is our other mentor. She's not able to be with us today. But if you're interested in either the program or maybe signing up to be a mentor, go back and talk with the wonderful staff at the Neuro Challenge Foundation table, and we'll be happy to give you some information on that. All right, so we hope you are enjoying your lunch today, provided by local proprietor Poopy's Place. So hopefully everyone's enjoying that, and we thank them for all of their service. They did our coffee and our water and our lunch today, so we appreciate them and love to support local business. And the volunteers, they're going to be coming back around to collect the boxes and all the other things, so you can just sit back and relax and keep enjoying the next speakers. And then when we're finished with the next speaker, we're also going to be followed by an exhibit break. So, everyone's what? Has everyone had lunch? Is anyone missing lunch? Raise your hand if you're missing a lunch. Are we good? This is a work in progress, right? Okay, so are we, April, are we ready? Yeah. Yeah. All right, we're gonna ask our fine friends from, you wanna turn a little music on? All right, we're gonna turn a little bit of music on while you finish up your lunch and we get ready for our next speaker. So enjoy the rest of your lunch, and in a few minutes, we're gonna welcome our next speaker to the stage.
Never
Okay, ladies and gentlemen, we are going to bring our next presenter to the stage to speak about how cannabis helps humans. Please welcome to the Expo stage, Dr. Daniel Stein. I had the pleasure of meeting Dr. Stein last night and know this is going to be a very interesting presentation, so welcome.
Okay, we have a added treat for you today. It's not just Dr. Stein anymore, it's Dr. Stein and the neurotransmitters. We have Diane, who's representing dopamine. Leslie is representing GABA. And Ellen, yes. And Ellen is, of course, glutamate. Because she's so energetic. And I know that a lot of you are familiar with the ups and downs, the on and off of dopamine. And it's important, I think, when talking not just about cannabis therapy, but talking about Parkinson's and other conditions, that we try to understand brain neurochemistry. Am I the only person that's interested in brain neurochemistry? Well, it turns out that when I started studying brain neurochemistry at 18 years old at University of Rochester, yep, I was a geek. U of R? Meliora. It was actually because I was getting high and I was curious how it all worked. And so I decided to study the neurochemistry of cannabis when I was 18, and here I am, full circle, finally trying to understand it. And it turns out that traditionally, dopamine, GABA, and glutamate as neurotransmitters were what we thought controlled behavior and movement and sleep and anxiety. But there's something much more than that going on in the brain. It's called the endocannabinoid system. And I'm going to, with the help of the neurotransmitters, try to explain the endocannabinoid system to you in a way that's not too detailed, but enough so you can appreciate how cannabis works. Now, dopamine, come on over here. This is probably the most important neurotransmitter for Parkinson's patients. We know that. Dopamine is in short supply because of nerve cell loss in the substantia nigra. And of course, patients take dopamine agonists like pramipexole and also dopamine replacement therapy like Sinemet to try to compensate for the loss of dopamine neurons. But there's other things that are going on in the brain that we can modify to help patients with Parkinson's. For example, GABA. GABA acts on dopamine neurons. So dopamine is like this, and then GABA, you put your hands over here like that, shake your hands around. So what's happening here is that the GABAergic neurons are slowing down the dopamine neurons. That's what GABA does. GABA slows things down. Whoa, so dopamine, you're slow. But glutamate is an excitatory neurotransmitter. Did some of you know that? I don't know. Well, anyway, glutamate. Show us some excitation of the dopamine neuron. What about these neurotransmitters, huh? All right, let's just pause. Now, when I was doing neuro at U of R and then at NIH, this is all we thought there was to balancing neurotransmitters and helping patients with neurological problems. But it turns out that there were researchers in Israel and also actually in Kansas City and at other places discovering what's called the endocannabinoid system. It's 6 syllables. Try it with me. Endocannabinoid. Endocannabinoid system is a system of chemicals that attach to receptors in the brain and control the other neurotransmitters. Who knew? All of that studying, all of that work, all of that treatment that I and other clinicians have been trying to achieve with patients, modulating not just these neurotransmitters, but others like serotonin and oxytocin and acetylcholine and so forth. Who knew that there was another system that actually modified and controlled all the neurotransmitters? And that's the endocannabinoid system. So I will portray the endocannabinoid system. Okay, so you're like lowering the GABA, exciting with the glutamate. Now the endocannabinoid system comes along and does this. Removes the GABA. I could do that on the endocannabinoid system. And what happens when the GABA is removed? The dopamine-containing neuron can be more active because I've removed the inhibition. Okay, let's say that there's too much glutamate and there's something that we call excitotoxicity. For example, in patients with epilepsy whose neurons are firing uncontrollably, way too much glutamate. This is how neurons die. One way is through excitotoxicity. So what do? So the endocannabinoid system modulates the control of neurons through balancing neurotransmitters. Let's give a big hand to the neurotransmitters. Thank you. Thank you. That's it. You guys can actually. Oh, thank you. Thank you. Thank you. I am not high right now. This is my normal self. My endocannabinoid system is tuned right now. But, you know, sometimes it's not. And sometimes we need to tune those endocannabinoids so we can control the rest of the neurotransmitters. And how do we do that? We use cannabis. That's why cannabis works. Cannabis binds to endocannabinoid receptors in the brain, and those receptors control all the neurons. We didn't know this until the 1990s. Doctors never learned about it in med school if they went before 1990, and now there's only 10% of medical schools that teach anything about the endocannabinoid system. The molecules in the brain that represent the endocannabinoids are called anandamide, which means bliss in Sanskrit, and 2-arachidonylglycerol. So just like GABA, glutamate, and dopamine, we have fancy polysyllabic names for the chemicals. Those are our endocannabinoids that we produce in our own body that bind to the receptors that control the neurons. It's the same as the endorphins. You know, when you use opiates, those opiates are binding to endorphin receptors. But our body produces endogenous molecules, endorphins, to bind to those same receptors. So I want, hopefully, to convey this analogy. We have our own biochemical cannabinoid system in our bodies that we can maintain and promote through healthy diet and exercise, yes, through gut health. And we also have exogenous cannabinoids in the form of phytocannabinoids. And phytocannabinoids are the molecules in the cannabis plant. Is it coming together at all? Okay. Well, this is the story of how cannabis works. And this is why there are so many benefits of cannabis therapy. It's almost like snake oil. When asked if cannabis can help a patient with irritable bowel syndrome, or glaucoma, or autism, or Parkinson's disease, the answer is yes. cannabis therapy can help all those patients with those conditions because the endocannabinoid system is the major homeostatic regulator of human physiology. The endocannabinoid system is the major homeostatic regulator of human physiology. I get choked up just thinking about it. They never taught me that in medical school. But in 2017, when cannabis became legal for medical use in Florida, many of my neurology patients, I'm a neurologist, I'm a real doctor, I'm not a snake oil salesman. Many of my neurology patients, especially patients with multiple sclerosis, came to me and said, well, by the way, we've been using cannabis for the last 10 years. It helps with my muscle spasticity, and it does work for MS patients. But now that it's legal, how do we get it? How do we use it? And so I'm going to jump into the real part of the presentation now and talk with you about some of the nuts and bolts about how in the clinic we start cannabis therapy so we can help patients with their symptoms. The first case study I want to talk about pertains to sleep, which actually someone was asking me about just a moment ago. And I want everyone to know that I have dinner reservations at 6:30 tonight, but I'm available till then. So if you want to meet me out front to talk with me about your specific question or needs or concerns, I'll be over by the True Leaf table. Sleep is one of the things that cannabis does best at. I probably could have said that a better way. Sleep promotion is a very important part of overall health. When we sleep, we rejuvenate, we renew, we recover. Very, very important. And Parkinson's patients have specific types of sleep problems that were highlighted last year at the Expo. There was a great presentation on sleep and Parkinson's disease, and that's available online on the Neuro Challenge YouTube channel. So you may want to take a look at that. This is a case of a high-functioning 77-year-old real estate CEO with 10 years of Parkinson's disease diagnosed, who has chronic insomnia and is basically dependent on benzodiazepines. Benzodiazepines are those drugs like Valium, Ativan, Restoril, which is temazepam, any of those sedative drugs which we use to help with sleep. Those are benzos. And frequent awakening. So the very first thing that we talk about in the clinic when someone is concerned about sleep is sleep hygiene. And again, this was covered last year, but I'm just going to mention briefly that not everything has to be cured with cannabis. Sometimes you can cure with lifestyle changes. So avoid caffeine, don't eat too late, make sure the room is dark and cold. There's all these different things we do that's called sleep hygiene. That's number one. And if you still have a problem with sleep after that, then we can talk about medication-assisted issues. And one thing that patients need is to help initiate sleep. And that's the question I ask. Are you having trouble starting sleep? Do you have trouble falling asleep? Or do you have trouble staying asleep? That's an important distinction. A lot of folks say both. And then we try to come up with a cannabis protocol, a treatment regimen for them. So for example, this particular patient is dependent on benzodiazepines. Let's say, for example, they take 30 milligrams of Restoril every night, and they've been doing that for the last 10 years. And they realize from their studies that these benzodiazepines can trigger dementia-like symptoms and affect cognitive performance, so they want to get off their benzos. So we use cannabis to help them get off their benzos and promote better sleep. And the way we do that is by using the proper cannabis product through the proper administration method at the proper dose. So 3 things. What is the cannabis product you're going to be using? Is it going to be THC, tetrahydrocannabinol? Is it going to be CBD, cannabidiol? Are you going to take it as a oral therapy, like a gummy or liquid tincture? And then what's the dose? 2 milligrams of THC, 8 milligrams of CBD. What is the dose? What is the administration method? And what is the cannabis product you're going to choose? And those 3 things for each specific patient and their specific problem needs to be figured out by someone like, I'm not saying I'm the only person that can figure these things out, but I've spent the last 7 years studying pretty hard on this, and I've educated about 1,000 physicians around the world. I'm on the faculty of a couple of different online self-education platforms for continuing medical education. And, you know, part of what I do is teach physicians, and because we don't know as a group. So, yes, if you have questions or concerns and you want to email me or call, I'm here for you. For patients that have trouble initiating sleep, they need to take their cannabis medicine in a way that kicks in quickly. The quickest way for cannabis to kick in is through inhalation. Most patients, though, are not really keen on inhalation if they're new to cannabis, and there's some drawbacks to inhalation. The next fastest way to initiate sleep would be to use liquid tinctures, drops under the tongue. That takes about 30 or 45 minutes to kick in. But if you're going to use a gummy, which takes an hour and a half to kick in, you have to take it 2 hours before bedtime. So just because your nephew from Michigan gave you a gummy, you know, and it didn't work, doesn't mean it's not going to work. Maybe you just took it at the wrong time. And then, of course, to maintain sleep, something like a gummy or oral cannabis would be a good solution, because when you consume cannabis orally, the benefit lasts 6 or 7 hours. And for sleep maintenance, you want your cannabis to last, right? Otherwise, you're going to wake up after a few hours when the inhalation wears off. Some patients need to take a short-acting, a rapid-acting, short-duration cannabis preparation to fall asleep, and then when they get into bed, they chew and swallow their gummy, so that when the inhalation wears off, the edible kicks in, and they get a full night's sleep. So we can stack the therapy like that. And what's going to be in that therapy? It's going to be THC, tetrahydrocannabinol. THC, delta-9 tetrahydrocannabinol, is the part of the cannabis plant that gets you high. I think probably at least 2/3 of you know that based on the aroma that I sensed out. But delta-9 THC, tetrahydrocannabinol, even though it has strong psychoactive effects at certain doses and will get you high, it's still very important in cannabis medicine. We need THC for sleep, not CBD. CBD at low doses, cannabidiol, at doses of 5, 10, or 15 milligrams could actually keep you awake. So all of these CBD vendors that are saying, oh, take my 10 milligram gummy to help you sleep, I don't think so. Sure, 10 milligram CBD can help you relax, but in 20% of people, it has an alerting effect and can keep you awake. So no, don't take that CBD gummy at bed. There's so much to share with you. Let me just say quickly that CBD can help with sleep, but at doses of 25 milligrams and higher. So sometimes for patients that do not want to use THC, we can use high doses of CBD to promote relaxation and sleep. But if you don't take the right dose, you're not going to have the right effect. You might even have the opposite effect. Our next case has to do with motor symptoms. This particular patient has a rest tremor with freezing and dyskinesia, 67-year-old man, who tried a gummy from someone at the boxing class. That actually may have happened, I think, to some people here. And success, the gummy worked. It reduced tremor and dyskinesia, but the poor guy couldn't get off the couch. So he had what we call couch lock. And that's because there was too much THC. You know, this is cannabis, it's weed, it's ganja, and it's fun to talk about it as a recreational drug, but that's not what we're doing here. We're talking about cannabis as medical therapy. There's a big difference between medical cannabis and recreational cannabis. And it all has to do with your intention. Sure, if you want to be locked on the couch with your iPad and Netflix, not that I know anything about that personally, I'm just saying, if that's what you want and that's what you want your cannabis to do for you, fine. But if you want to reduce dyskinesia and use your THC in a way that still allows you to function, then you have to take the right dose. If you don't take the right dose, you're going to be on the couch. So that's the difference between medical and recreational cannabis. It's all about the intention. I see a lot of patients, just as an aside, that have been using cannabis their entire life as basically recreational. They use it to help them relax, and that's fine. You know, I've actually been using cannabis my whole life. But when it comes to using cannabis as a medication, you have to be more mindful of what you're doing. What is the goal you want to achieve? What dose do you want to take? And what do you want to avoid? What side effects? What drug-drug interactions are you concerned about? So those are all things we take into consideration when talking with potential cannabis patients. This particular patient needed a reduction in the THC dose. And sure, one gummy is usually 10 milligrams, but a quarter of a gummy usually is 2.5 milligrams, and that turned out to be the perfect dose. And that patient was able to reduce the hyperkinetic movement disorder. That's what dyskinesia is. It's hyperkinetic. If you use too much cannabis, though, it'll slow you down and you'll be on the couch, you won't be able to move. So patients who have freezing or bradykinesia and use too much cannabis, the cannabis can make them worse. So be aware. Dose is everything. And one way that we control the effects of cannabis is by adjusting the amount of CBD and THC. So oftentimes, the ratio of CBD to THC is an important indicator on the effects of cannabis. Some of you may have used THC and found that it caused too much psychoactivity, made you anxious, paranoid. It was a bad experience. Understood. That does happen. When you combine CBD with THC, it mitigates the psychoactive effects of THC, reduces potential anxiety. We have all sorts of professional, high-functioning adults in our clinic. Did I mention I had a clinic? We've treated 5,400 patients in the last 7 years. Crazy, crazy. High-functioning individuals. I know that, and I'm sure they can attest, and please do, share your success with the people next to you later. If the THC is too strong or will impair your ability to do your job or look after your grandkids, then you need to combine CBD with THC to mitigate the psychoactive effects. You need to take that medicine in the proper ratio with the proper milligrams, and you'll succeed. And I can tell you that we have a very high success rate, but it takes time. It usually takes about 2 or 3 months to figure this all out because we start low, we go slow. We don't want patients to have side effects. But if you do have psychoactivity and it's too strong, so you crank up the CBD, lower the THC. That's one possible solution. Next case. Last case. 34-year-old recently married veteran, has dream enactment behavior, and a positive family history of Parkinson's disease. So this individual has not been formally diagnosed with Parkinson's disease, but has a condition that's often referred to as rapid eye movement, REM, sleep behavioral disorder. I'm sure some of you have that. Can I see a show of hands if you've been told or think you might have a sleep disorder? What happens with REM behavior disorder is instead of being paralyzed during dream sleep, which is the normal way sleep works, those patients are actually moving with their dreams and enacting out their dreams, punching or kicking or running, and it can be dangerous to themselves and their bed partners. And it's one of those conditions that often is a warning sign of Parkinson's disease. Loss of sense of smell and dream enactment behavior can be early warning signs of impending Parkinson's disease, and it has to do with alpha-synuclein deposits in the brain. We also see that in dementia with Lewy bodies and multisystem atrophy. So, yeah, I'm so smart. But the point is, if you have dream enactment behavior, if you are at risk for developing Parkinson's disease, you want to protect those neurons. And this goes pretty much for all of us. Cannabis can help protect neurons. As we age, not only are we at risk for degenerative conditions like Parkinson's and Alzheimer's, but normal aging also can affect our ability to function through loss of neurons. Cannabis therapy, this is the snake oil part, cannabis therapy can help prevent aging in the brain. And it does that by providing antioxidant, anti-excitotoxic, and anti-inflammatory effects. So much so that in 1999, researchers at the NIH published, what's the word I'm looking for? It was a patent. They published a patent on the neuroprotective antioxidant. See, I didn't use my cannabis today. Researchers at the NIH published a patent discussing the neuroprotective antioxidant effects of CBD and THC. And that is available online, and it's a beautiful piece of literature. Cannabis protects neurons. Now, you can't be high all day protecting your neurons. You won't be able to function. So you need to use a combination of cannabinoids, like CBD and THC, and THCA and CBDA, which are acidic cannabinoids. We also use the aromatic molecules, the terpenes. That's what gives cannabis its strong aroma. We use these different molecules in the cannabis plant to protect neurons from damage due to too much glutamate. Remember, I demonstrated with our neurotransmitter team how the endocannabinoid system turns down the volume on the glutamate neurons. The antioxidant effect of cannabis is more potent than vitamin E or vitamin C. I could show you that data if you want. And finally, the cannabinoid receptors that I told you are all throughout the brain also live on the lymphocytes, the microglia in the brain. So if you have an inflammatory condition where there's overactivity of inflammation, guess what? The endocannabinoid system can calm that down, because remember, the endocannabinoid system is the major homeostatic regulator of human physiology. Thank you. I just get choked up when I say that. I showed some references there quickly. If you want to learn more, you can find those when the talk is published. Thank you.
Thank you, Dr. Stein.
And now we'll have a brief message from our diamond sponsor, Supernus Pharmaceuticals. Please welcome Tamina to the stage.
Hello, everyone. My name is Tamina, and I'm with Supernus Pharmaceuticals. This is probably my 4th Parkinson's Expo, and it's always a great turnout, and I'm really excited that all of you are here because the best thing you guys can do for yourselves is be your own advocate and find out what's new out there. With Supernus, we have a couple of medications for Parkinson's. One is GoCovery, and it's just extended release amantadine for levodopa-induced dyskinesias as well as off episodes. And another medication by the name of Apokyn, which has been out for many, many years, and it is for acute off episodes with Parkinson's. It's a subcutaneous injection. And we're very lucky today because we have Joe, who many of you have met before. He spoke here years ago with his wife, Sarah. So he's our little celebrity back there, along with we have another celebrity, Anna. She is on the other medication, GoCovery. So please be sure to go to the booth on the far right side by the south exit and visit our booth at Supernus, and we have Apokyn and GoCovery. Thanks.
Thank you, Tamina, and thank you again to Supernus Pharmaceuticals, our diamond sponsor. We very much appreciate your support and the support of all of our sponsors here at the Parkinson's Expo. Folks, we at Neuro Challenge are so proud to bring you this expo every year, along with all the programs and services that we offer at no charge throughout the year. So again, I'm going to put one more little plug in. If you find it in your heart to give us a donation today, we would be very appreciative, and you can see the folks at our Neuro Challenge table, or simply scan the QR code on the back of your expo program. Next up is another exhibitor break, a chance for you to stretch your legs, get out there, see, interact with our exhibitors, and take part in our demonstrations. We have a lot of fun physical demonstrations today: the ballet, health pit from SMH, PD Life, cycling with Well Studio, chair yoga. Go out there, have a good time. We will see you back here at 1:15. Folks that are joining us live on our virtual stream, again, we will see you back here at 1:15.
Go. Ladies and gentlemen, we hope you are enjoying your break, visiting all of the vendors and sponsors, but don't take off just yet. We've got 3 amazing speakers that are going to round out our expo today. Dr. Lotia is going to be talking on nutrition and Parkinson's disease. I just had a wonderful conversation with him. You're going to enjoy his presentation. And then we have the very special presentation by Dr. Peter Tass. And rounding us out this afternoon is going to be Kanwar Bhutani. So don't take off just yet. Join us back in a few minutes.
Clap along Because I'm happy. Clap along if you know what happiness is to you. Because I'm happy. Clap along if you feel like that's what you want to do. Because I'm happy. Clap along if you feel like a room without a roof. Because I'm happy. Clap along if you feel like happiness is the truth. Because I'm happy. Clap along if you know what happiness is to you. Because I'm happy. Clap along if you feel like that's what you want to do. Bring me down, can't none bring me down. The love is too high. Bring me down, can't none bring me down. I said, cause I'm happy. Clap along if you feel like a room without a roof. Cause I'm happy. Clap along if you feel like happiness is
seats. The program will resume in 5 minutes. Thank you.
She's calling a cab while he's having a smoke, and she's taking a drag. Now they're going to bed, and my stomach is sick, and it's all in my head. But she's touching his chest now. He takes off her dress now. Let me go. And I just can't look. It's killing me. And taking control. Jealousy, turning snakes into the sea, swimming through sick lullabies, choking on your alibis. But it's just the price I pay. Destiny is calling me. Open up my eager eyes. 'Cause I'm
Please make your way back to your seats. The program will resume shortly. Thank you.
I'm coming out of my cage and I've been doing just fine. Gotta be down because I want it all. It started out with a kiss. How did it end up like this? It was only a kiss. Now I'm falling asleep and she's calling a cab while he's having a smoke, and she's taking a drag.
Welcome back, everybody. Did you have a great break? Yeah? We love our exhibitors and our sponsors. It is my honor now to welcome our next speaker as we kick off our afternoon program. Dr. Mitesh Lotia is here to talk to us about nutrition and Parkinson's disease. Dr. Lotia.
Good afternoon, everyone. Hope that you all had a good break. And just a disclaimer, I'm just recovering from a sore throat, so if my voice crackles, it's not because another Friday night happened. So I'm a movement disorder neurologist. I'm based in Orlando. I work with Advent Health. I'm the medical director for our movement program. And I've been there for 2 years, and we've been building our movement disorder clinic. I'm very excited to be here, and again, I thank Expo here to partner with us. It's amazing to see this excitement and have everybody here learning and listening about Parkinson's. So I'm going to talk about nutrition. Another disclaimer, I'm not a nutritionist, but I'm a clinician scientist who is always interested in how food can change our brain and our body. We often talk about we are what we eat, and I really abide by that, and that's important to me. So today I'm going to talk more about scientific approaches to the nutrition and diet and the gut and brain axis. So we'll hope to learn from all of that. So I always like to start this slide discussion with this slide. Back in the days when we thought of Parkinson's, we thought of somebody frail, old individual, just kind of shaky and then shuffling. But at this point, we know that's not the case, right? We always say that. No two patients are the same. No two people with Parkinson's are the same. And we understand that now, so we almost kind of call it as more of a syndrome. Oops, sorry, I'm going to go back. Where some people, especially those who get it young, they may have more of just a little bit of a tremor, a little bit of a twisting, turning movements of their body. When they are on medications, half the time people don't even know that they have Parkinson's. Later on, some of these may go on and develop some fluctuations. They may have some dyskinesia. And then there are others who may have that malignant Parkinson's where they rapidly progress to needing the walker, the wheelchair, develop some cognitive issues and things like that. So the idea to understand here is that everybody progresses differently, everybody gets affected differently. So it's important to understand the basics, but not to relate yourself to someone else, especially if they are suffering. So it's important to keep that in mind. How common is Parkinson's? We believe it affects 1% of our population, about 10 million people affected worldwide, 1.2 million affected in the US. One of the trend, what we're seeing now is we are seeing a rise in the Parkinson's population. In our study in 2008, we saw there were about 60,000 new people were diagnosed every year, but now we're already touching the 90,000 newly diagnosed patients. We're trying to understand that. We believe there is some environmental factor, there are some environmental factors that are playing a role. But the point is that the incidence is rising, and it's equally important not only to find a cure, but also in the meantime, learn together and see if there are certain strategies we can do to help improve the quality of life. We don't understand why Parkinson's happens, but this is our proposed hypothesis. It's a balance. Our body is in a constant balance. But what we understand is there are certain risk factors, genetic risk factors that predispose us to developing Parkinson's. About 10% of people with Parkinson may have it due to a genetic mutation. And then we add about lifestyle, where we talk about our overall level of activity, not just in our senior years, but also in our middle ages and younger years. And then we talk about exposure to certain things, certain pesticides. So some things such as traumatic brain injury, pesticides have been associated with increased risk of Parkinson's. whereas there are some genetic factors that are protective, meaning if you have a certain mutation that may protect you from developing Parkinson's. Similarly, there are certain diets, certain lifestyles that are protective. So we know people who have been more active, we know people who have been on certain diet have had relatively reduced risk. And when that balance gets affected, that's when we see people developing Parkinson's. That's our current understanding. As we talk about Parkinson's, we understand what does it do. So you see the first image to your left, you see the reverse Mickey Mouse. That's basically, if you cut it into half, the control side, it's a reverse Mickey Mouse where you see the ear and the face, and you see the nice black line. That's the bunch of neurons called substantia nigra, and those neurons are the ones that produce a chemical called dopamine. You can see on the right, the one with the PD, that entire neurons are lost. So that's what we see, that those neurons that are producing the dopamine, they're disintegrating slowly, and then that's what causes people to have Parkinson's. Why does this happen? Because of one of the toxic protein called alpha-synuclein that starts getting misfolded, and it folds into another toxic protein called Lewy body, okay? So you're gonna hear a lot about Lewy body and inflammation, but basically it's the Lewy body that enters the brain and then it slowly propagates. So this is the most accepted hypothesis. We call it as the Brock hypothesis. It's from 1990s. What we understand is these Lewy bodies enter the brain either via the gut. So you see one red dot at the end at the brainstem. I'm trying to figure out if there is no way that I can project it, but you can see the small red dot coming from the edge of the brain, and then the one small red dot coming from the nose. So either we believe they enter from the nose or they enter from the gut. Okay? That's why many people actually have constipation for many, many years before they develop Parkinson's, or they actually have lack of sense of smell for many, many years before they develop Parkinson's. Once they start depositing into the middle part of the brain, then from there on, slowly they progress to the rest of the brain over decades. So stage 1 and 2, very, very early. Most commonly, that's when people may not even have symptoms of Parkinson's. Then stage 3 and 4, where mostly people are diagnosed and slowly progress on. And then 5 and 6 is where we see progression to the rest of the brain. And we are still trying to understand how these toxic Lewy bodies are propagating across the brain. We know that there is inflammation in the brain at a microscopic level. We don't think of these as necessarily an infectious process, but there is something that is making them to propagate further. And that's what, as a community, we're trying to learn more. That brings me to our discussion of gut and brain connection. As you see, these are the charts. So this is just, our Google search is our PubMed. When we look at number of studies that are being done for gut and Parkinson's. So on the left, you see the studies with gut and Parkinson's, and you can see from 1970s to early 2000, there was hardly any research being done. Suddenly, people started to pay attention to that, and then the last couple of decades, I've seen a critical amount of research come out. And the same way for diet and Parkinson's, because we have understood how important it is to connect the gut to the brain, and how important it is to keep our nutrition under check, especially if we were to fight this disease as long as we can. All right, so what's the connection? So we have understood that, remember I told you that Lewy bodies enter the brain from somewhere. Actually, they enter the brain through a nerve that actually, a vagus nerve that supplies the gut, and that's what makes our gut move. And we believe that the Lewy bodies actually come from that. That's one of the possible entryway. So we've been able to do a lot of the proteomic and other studies on the gut, and we're able to identify multiple organisms. We have identified almost quadrillion microorganisms that live in our gut in symbiosis. All right? As over time, with aging, with our lifestyle, with our diet, these microorganisms are changing. All right? And what we've understood that in Parkinson's, people with Parkinson's, there is abnormal alteration of that gut. We have actually identified few early microorganisms that are more commonly seen in people with Parkinson's than general population, okay? We're in very early stages of this, but we are understanding this now. What we understand by that is that's what makes the gut more inflamed and kind of leaky. And we believe maybe from there, maybe these Lewy bodies kind of start propagating to the brain. And that's our current understanding. However, we still need to study more. We still need to now strategize in a bigger population, in a bigger stool samples and colon samples to look at, and then identify, are there actual specific microorganisms that could be doing this? And I could give a lecture on the whole 1 hour just for the possible infectious cause of developing some of these neurodegenerative conditions. So this is another way to look at it. So you see two figures. One on the left, what that shows is which other body parts we have actually found that toxic protein, the alpha-synuclein. So all these years, right, people used to think Parkinson's is a brain disease. Well, it's not, right? It affects actually rest of the body as equally. So often we are one of the very few doctors who will take the blame for almost every symptom that the Parkinson's patient may have because we know how multiple systems are affected across. And as of now, we have found these samples of the toxic protein, not just in the brain, but in the salivary glands, even in the saliva. We found the samples of the toxic protein in the food pipe, in the stomach, in the colon, and now in the skin. In fact, nowadays, we do a tissue sample of the skin sometimes to help diagnose people with Parkinson's in the early stages. All right? And the second figure kind of tells you about how different symptoms people may manifest with Parkinson's. So often people think of slowness, tremors, and balance issues, right? There is more to it. We often talk about constipation. We heard a beautiful talk in the morning about cognition, neuropsychiatric manifestations. It can affect also trouble with urination. Many men come to us with their issues with sexual dysfunction. Even many women come and talk about that. It does affect the sweat glands. It affects the heart in later stages. So it does affect entire body, and that's what we understand. These synuclein is there pretty much everywhere, but we believe it may be starting in the gut. All right? Besides the onset of the disease, when we talk about gut and Parkinson's, how many of you feel you have had constipation? Right? It's pretty common, very common. But then later on, we have many folks who develop swallowing difficulties. Weight loss is what we deal with sometimes, dehydration. And then, of course, there are issues with medications where there are not only just absorption issues, but there are issues with protein consumption, etc. So all of these things come into the play when we talk about Parkinson's and their symptoms. So as we then move our discussion to the nutrition, right? So what do we mean by nutrition? Whatever we consume in a day to have a calorie intake that builds our building block for not only our body, but for also our brain. We talk about healthy diet, and then we talk about balanced diet. Healthy diet is generally what you picture as healthy diet. Lots of vegetables, lots of fruits, a little bit of that French fries, little less of the chicken wings, right? However, the idea is to put that into then a perspective is what is balanced diet, and that's what is important. So then in a balanced diet, you want to make sure all your macronutrients, such as carbohydrates, your lipids, the proteins are involved, along with micronutrients, all the essential vitamins, minerals, and other essential amino acids are actually included as part of your balanced diet. So every time you eat, we want to make sure those important nutrients get absorbed as well. We know that in Parkinson's, even the absorption gets impaired, and especially in certain stressful situations and in neurodegenerative conditions, these absorptions get even worse. And sometimes with that, you have decreased cellular function, decreased repair, and of course then that leads to reduced recovery and more inflammation. So there is that nutrition connection. So as we talk about balanced diet, you've heard a lot today about Mediterranean diet. the general idea has been there for now a couple of decades that generally a Mediterranean type of diet has been helpful not only just for overall health, heart health, but also for brain health. Now, what does that Mediterranean diet comprise of? It has that pyramid system. Okay? Look at that, take a photo, but don't forget the base. We always say, yes, the diet is important, but at the same time, that physical exercise, that physical activity, and socializing is equally important. Sorry. So, anytime you compare with your Mediterranean diet, the major portion of it should be, vegetables, fruits, whole wheat grains, olive oil, beans, nuts, legumes, etc. And then a little bit of the fish and seafood in the way of protein. In moderate consumption, you can have maybe, poultry and egg products, and then less often meat, especially the red meat. So very less often of red meat, and in moderation, wine. But of course, the important part is the water. And that's how you should look at the Mediterranean diet. And we at this point know that this helps. These are the hypothesis, or these are the ways we think that it actually helps. So there are many different micronutrients besides the macronutrients that we talked about. The complex carbohydrate that comes from the complex wheat, and protein that comes from the legumes, and then vegetables will add the antioxidants. So as you think about these macro and micronutrients, each of them have certain role. They minimize the inflammation. We believe that actually it also adds more neuroprotection. And what does the word neuroprotection mean? Is you are minimizing the inflammation. So that whole idea of Lewy body progression, if you minimize the inflammation, you are preventing further injury. And by preventing further injury, you're protecting the brain from getting damaged. We always say that, especially for brain. Brain heals by leaving a scar tissue, so it's better not to have a scar tissue. It can rebuild around it, but the best way to do it is not to have an injury, and this is one of the ways to do that. Other type of diet is a DASH diet. Basically, that was, again, tried for heart approach, but holds true for Parkinson's and brain health as well. DASH is dietary approach to stop hypertension. So similar idea that a lot more vegetables, lot more complex grains and protein, little bit of low salt, and just one caveat to remember in the DASH diet or low salt diet, many of our people with Parkinson's struggle with orthostatic hypotension, where their blood pressure may drop when they stand up. And actually in those individuals, we propose to add more salt. So just have to be mindful of that. However, in the early stages, and if overall your health is good, DASH diet is a very good way to help minimize some of the progression as well. Next one, or more recent one, is a MIND diet. So what is a MIND diet? So combination of Mediterranean and a DASH diet together. And the idea was to see what if we actually had individuals who had a MIND diet, and we looked at them over years to see if we were able to minimize the chances of them developing dementia or any other brain health issues. So this was actually done out of Rush in Chicago, where they had, it was a 10-year project. They had more than 1,000 individuals who were basically surveyed about their yearly dietary requirements. And they were asked to fill in a survey talking about percentage of food they had into their routine. And they also had 2 cognitive assessments as well. They were all given a score, a MIND score. Higher the score, they were more closer to that whole idea of a MIND diet. Again, what that would mean is, again, more servings of the whole grain each day, a lot more berries at least twice a week, at least one dark, green vegetables, and then seafood, and less of, the fried food, etc. So the closer they were to that MIND diet, the higher the score was. And what they found is participants with the higher mind score were less likely to develop dementia, less likely to develop neurodegenerative conditions. Now that's a big, big statement, right? Now we're saying, well, you can actually change your lifestyle a little bit, be more mindful of what you eat, and actually you can minimize the chance of developing certain conditions that actually, as of now, have no cure. But again, I want to remind you that with this, you want to inculcate your active lifestyle, which includes physical and social activities as well, and cognitive activities. Then the study was reciprocated in Swedish and Greek cohort, and they found similar results. And it's still continuing to be looked at, especially in our Parkinson's population as well, and we seem to be getting good data. Another interesting finding we saw is that people who were on MIND diet, women actually had later onset of the cognitive issues compared to men. It was an independent benefit as well. So again, just emphasizing the role of nutrition and diet. All right. Often people ask us, what are the benefits? I've been eating this diet. Why did it not protect me? Or I've been eating this. Is it going to protect me from developing Parkinson's, specifically Parkinson's, okay? So when we talk about summary of evidence or risk or benefit in people with Parkinson's disease. So when we talk about macronutrients, so again, carbohydrates, proteins, fats, we don't think that there is any increased risk of developing Parkinson's if your diet is heavy in one. Then what we have understood that the PUFA, the polyunsaturated fatty acids, they do provide some neuroprotection by minimizing the inflammation. And then when we look at the micronutrients, there is, again, the dietary antioxidants that we all talk about that does have a role in the neuroprotection. We have looked at some of them specifically. We looked at vitamin E, initially showed some benefits, but we were not able to see the benefits across. Vitamin C or vitamin A also did not have any major benefit, neither did vitamin B or folate in terms of prevention of developing Parkinson's, okay? There was one thing that people who had higher homocysteine levels, they had worse motor outcomes or cognitive outcomes. And we looked at heavy metal, minerals, etc. that had no association. So generally by this, what I'm saying is, I typically don't recommend a nutritional supplements or vitamin supplements for people with Parkinson's unless they actually either have deficiencies or we check it and we are able to track it, all right? Some other things, so coffee, a lot of studies have been done for coffee and caffeine and prevention of Parkinson's, and we've had some mixed results. There are some components within the caffeine which we believe are neuroprotective, especially the polyphenols and the A2A receptor antagonism. And we are looking into that. In fact, a couple of trials are being done right now to look at potential slowing down the disease. We call it disease modification. Similarly, tea has been looked at, and tea has been found to be beneficial, but again, the same idea that it's a polyphenol and it may be that could be having the anti-Parkinsonism effect. There are people with urate, high levels of urate has been associated with reduced and slower progression. So again, trials are being done to artificially elevate the urate levels in the body to see if it can slow things down. There were some concerns that high consumption of dairy was associated with increased risk of Parkinson's, but in bigger studies, we haven't found that substantially as yet. And then people always ask me about alcohol. So I believe it's a U-shaped association, which is true for majority of the things. What does U-shaped association mean? Either completely avoiding it or doing it too much of it is disastrous to the brain and body. But there is some benefit that if alcohol is done in some moderate consumption, it is good for brain health. Often people ask me when I diagnose them the first time, okay, sir, you have Parkinson's, or ma'am, you have Parkinson's. The second question sometimes gets asked, does it mean I have to stop drinking my alcohol? The answer is usually no, you don't have to. You can still enjoy your cheese and alcohol. You can still enjoy your trip to Italy. There are some interactions with some of the medications, but we have understood that somebody would have to consume cheese and alcohol in much larger quantity. Typically for cheese, it's like a kilo of cheese that you would have to consume for a day to have that sort of interaction. So if you're not eating that much of cheese, you're okay. All right. Some other consideration, as I already spoke about constipation, it's a very big issue for many folks right from the beginning to all the way as the disease progresses. And again, there are multiple factors. It's just that the gut is slowing down, and then some of the medications can make the constipation worse. Again, you can define that in a range. Some people just feel like they have to try harder, to some people who are like, well, I don't have bowel movement every day, and then some who are like, I have to have a bowel movement, otherwise I feel really, really stuck, and then in fact leading to stool impaction. So there's a big range as to where it can affect individuals. So generally what we say is, again, a high fiber diet is going to be very, very important. So what's a high fiber diet? So think of any of your bran, your nuts, your seeds, any of the green vegetables. So all of them have a pretty good fiber. We often talk about probiotics, the prebiotics. There is some role of probiotics, but generally I would say if you stick with fiber and hydration, usually that does a good job. And then exercise, the more you move, your gut moves as well. And that certainly can help with your constipation. There are some medications, if you have to take it, then usually a stool softener would be a good start. Miralax are preferred. And sometimes if you think you're still struggling, I would say go ahead and use it consistently so that way it can help you. You don't have to have a bowel movement every day as long as you're not in discomfort. And then very, very rarely there are people who may need regular enema. So that's something that may have to happen. This is one of my favorite recipe that I often prescribe. It's by University of Michigan Rancho recipe, which is basically a combination of applesauce, oat bran, wheat bran, and then some prune juice. I know many folks don't enjoy prunes by themselves or prune juice, so then you can combine that with the applesauce. And then you can mix it, you can keep it in the fridge, and you can use it just 1 or 2 spoons every day. It's one of the good ways to help with the constipation. Often I get asked about protein. So there is some discussion about protein affecting the absorption of medications. Generally what we have seen is about only 30-40% people notice the fluctuations when they take the medicine. So especially early in the disease, I almost always say, don't worry about it. Actually take your medications with the meals, because in fact it will help you with your nausea. And we're talking about a disease that's going to be with us for the rest of our life. We cannot say that you need to stop using protein. Protein is the biggest building block of your body. So if you notice fluctuations, what we try to do then is, what I usually suggest is maybe have a heavy protein meal at the end of the day. So even if there is a fluctuation, that's the end of the day. And then if we notice consistently that the medications are not lasting, maybe we'll just try a higher dose of the medication. But the protein is important. So let's not avoid protein, but then we can play around it by just giving it much more heavier meal at night. So that's one strategy to look at it. In fact, in later stages, when there is a loss of muscle mass and there is a weight loss, we in fact prescribe protein supplements to keep up with the weight and with the muscle loss. So it's important to keep that in mind. Other challenging issue that may come on is the trouble swallowing. Especially more common in later stages. So it can be that people just have to chew harder, or they cannot make a small bite. So again, lack of appetite, everything can add on to it. So what we usually say is, like, in those situations, definitely try to get the speech therapy, make sure there is no other reason. Even if there is a swallowing difficulty, you can start working with speech therapy and improve the swallowing function of the muscles. And then definitely resort to high calorie meals and small bites as we go up, and then add some thickeners. And then the other question I get asked is about weight. We typically don't see weight gain in people with Parkinson's. Maybe a couple of situations like dopamine agonist or DBS, there may be some weight gain with those situations, but generally weight loss is a theme. But I do always mention, especially in early stages, people who have had overweight or obesity, they are more likely to have a quicker decline in their mobility. So if you're in the range of overweight or obesity, then it may be a good idea to actually start exercising, again, living that healthier life to, again, minimize that dependency chance over time. And then later on, there is definitely some concern for weight loss, and we actively have to watch it. And we do talk about, again, high calorie meals, protein supplements, and be very, very careful and conscious about the artificial feeding discussion. So that's just one thing that I want to add. I'm sure you've seen this before, but this is another prescription that I always prescribe is exercise. My patients are very, very good at following directions when I tell them, here, take this pill 3 times a day. But at the same time, then rest of the things don't come along. So I've started prescribing exercise, and I've started prescribing social and cognitive exercises as well. So 30 minutes of rigorous physical exercise where your heart rate gets up to that range. Again, we've talked about this, you've heard this earlier in the day as well. You have to be mindful and conscious of it to be able to do this. So 30 minutes, 5 days a week, 150 minutes a week is your magic number to help build that muscle, minimize progression over time. A few more slides and I'll be done. So we talk about this theory about care of people with Parkinson's, where Dr. Oken with Shands has mentioned that we should think of patient as a son, and then everybody else around us are in the planet. So your neurologist, your PCP should be the closer, followed by rehab expert should be the next closer, and then some folks such as pulmonologist, neurosurgery, sleep therapists, sex therapists, dentists, they all should be in the peripheral as well. But they all should make a circle to take care of the needs, because that's what it needs to take care of our people with Parkinson's. And I'm very fortunate that we have that team at our Advent Health Neuroscience Institute in Orlando, where we have moved to a tower where everything is within one building, including MRI, clinical trials, and our floor and rehab, and our neurosurgery partners as well. We have also started our multidisciplinary clinic where you see patients not just by the movement disorder doc, but also the PT, OT, speech, the social work, and genetic counselor will discuss with you. It happens twice a month as of now, and this is the team we have built up just in the last 2 years, and we are more than happy to take care of our patients as we build our programs. This is our information, and again, thank you all for being here. I love the enthusiasm, and I love what you guys have done over the years to build this expo. This is our conference information that is coming up. It is about lifestyle medicine and lifestyle adjustment about Parkinson's. So we'd love to see you there in Winter Park in April. That's it.
Thank you so much, Dr. Lotia. A lot of really practical information there. And remember, if you missed anything, if it was hard to write it down, all of these presentations will be available after the fact on our YouTube channel at neurochallenge.org, so be on the lookout for that. Our next speaker is going to be coming to us live from Stanford University in California. Dr. Peter Tass is going to be speaking about vibrotactile coordinated reset stimulation, say that 3 times fast, for the treatment of Parkinson's disease. So he's coming to us live over the internet. And Dr. Tass, take it away.
Thank you so much for the invitation. It's a real pleasure to join you from stormy California. I hope you have better weather than we do have currently. Hope you can see my screen. So what I'm talking about is a treatment approach that uses stimulation in order to change brain connectivity in a way that we induce long-lasting effects, long-lasting therapeutic effects, by making the brain unlearn the affected brain circuits, brain networks, unlearn abnormal connectivity patterns. Parkinson's disease is characterized by abnormal neuronal synchrony. So synchrony intuitively sounds nice. Everybody's doing, so to speak, the same thing. That's not good in the brain because different neurons have different jobs, information processing jobs. Think of a company where all employees do the same thing. It wouldn't work. And it's also characterized, and this is tightly related, by abnormal synaptic connectivity, meaning the connections, patterns of the connections of the neurons are abnormal. And you're, of course, aware of deep brain stimulation. Deep brain stimulation was a major breakthrough in the treatment of Parkinson's disease. What you see here is the Parkinson patient, 48 years old, right-sided, right-handed person. And he received deep brain stimulation of the VIM, ventral intermediate nucleus, the thalamus, so the electrode is here. Here's the cable, and here's the generator. Everything's implanted, and he benefits beautifully. And the important message comes now. So when you turn off the stimulation, the symptoms come back immediately, tremor comes back immediately. And this was what triggered the entire development. I was really intrigued by the huge effect size, but wanted to do it in a more, let's say, specific way. And the point here is, and why? In the meantime, we know that deep brain stimulation is a super important treatment for Parkinson's disease, standard treatment for medically refractory Parkinson patients, but it doesn't have long-lasting effects, which comes with, of course, a certain load of electricity and hence also side effects, because you do not only stimulate structures you'd like to stimulate, you cannot spare some of them. In the meantime, there's the term DBS, deep brain stimulation induced movement disorders. And deep brain stimulation has also some limitations concerning efficacy. For example, it can result in speech deterioration and is not really good in treating gait and other so-called actual symptoms, balance, and so on. The approach I'm talking about is computationally based, meaning it's based on mathematics, physics, computer simulations. The key is to use self-organization principles of brain and the nervous system. And the starting point was to specifically counteract abnormal neuronal synchronization by desynchronization. That's super important. So it's not, you can do all sorts of things to synchronous neural populations. You can block them, inhibit them, or whatever you can. You can induce artificial rhythms or artificial firing patterns. The goal here is to specifically counteract abnormal neuronal synchrony, abnormal rhythms by desynchronization without stopping the neurons. And what's been shown with great mathematical precision is that plastic neural networks, meaning neuronal networks with synaptic plasticity, with structural plasticity, they can be in very different states. For example, this is shown here. You have a bunch of balls. Each ball symbolizes a neuron, and they're strongly connected. And what you see is the so-called firing pattern. So the x-axis is the time axis, the y-axis is the neuron index. So it shows all the fired time points. The dots are the timing points when the neurons discharge, and you see they're in perfect synchrony. And here they are weakly coupled. Their interactions is weaker, and everybody is doing its own thing, so to speak. They are no longer rhythmically discharging as a whole. And the important point is that we've shown that these neurons, these states can be stable, very stable, but desynchronizing stimulation can move, think of a landscape, potential landscape that you might know from physics or chemistry. That we can move the system from one state, a pathological state, a synchronous, strongly coupled, to a desynchronized and weakly coupled state. And that's the goal. And this was what we've shown and been working on in great detail and still working on computationally in order to further optimize this. And coordinated reset is one of the stimulation techniques, desynchronizing stimulation techniques that we've developed. What does it mean, coordinated reset? And this is now explained in terms of deep brain stimulation. So we have different stimulation contacts. And here is schematically the neuronal population that you want to stimulate. So each ball corresponds to a neuron. And we do not stimulate in a strong manner, in the sense that we go high up with the amplitude in order to, for instance, block, inhibit, or whatever, induce a functional lesion or whatever the mechanism of deep brain stimulation is. But we stimulate in a comparably weak way by resetting different neural subpopulations at different times. So we have a huge neural population which stimulated different sites at different times. And prior to the stimulus, everybody's in synchrony, all of them are in synchrony. And after stimulation, they are out of sync. And that's the important point. So they run through cluster states and desynchronized states. And the important thing is when neurons are strongly synchronized for a long period of time, they are so wired. That's the old Hebbian principle, something that we understand quite well in the meantime. But if neurons are not strongly synchronized and they are desynchronized, they are firing in an uncorrelated manner, their synaptic connections get weakened, ultimately they're improved, they even vanish. And the stimulation pattern looks as follows. So we have a periodic backbone, this period, for instance, in the range of the dominant pathological rhythm, the frequency of the pathological rhythm. And then we have sequences of comparably mild stimuli. So it's compared to standard deep brain stimulation. They are smaller by a factor of 3 to 5. And these sequences are randomized from cycle to cycle, and then there are off cycles where there's no stimulation delivered, and again, stimulation. And this is how it looks like, for example, in monkeys. These are macaca mulata. This is 16-fold velocity. It's a measurement cage measuring the movement production rate. This little head protects the monkey, protects the electrode from being pulled out by the monkey. It's an externalized stimulation. All monkeys were in this cage every day for 90 minutes. And the light barrier system of this measurement cage enabled to monitor and measure the movement production rate. And what you can see here is these are macaca mulata. They do not have tremor after MPTP treatment. So MPTP is a neurotoxic substance rendering the monkeys Parkinsonian. And they don't have tremor, but very pronounced, as you can see, akinesia or bradykinesia. And this corresponds to late-stage symptoms. So after such an MPTP treatment, the monkeys only have something like between 5 and 10% of the dopamine-producing cells surviving. And this is the same monkey. All of the monkeys didn't receive any medication throughout the study. That's important. So this is the same monkey. And as you can see, after 2 hours stimulation, so 2 hours coordinated reset stimulation, and then again put back into the measurement cage, again 16-fold velocity to show you 10 minutes representative window. And the monkeys there was no difference of the monkeys compared to normal, healthy monkeys not treated with MPTP. And the important point was that the effects last. So what we did was we tested different types of deep brain stimulation, standard deep brain stimulation, coordinated reset stimulation. And after 5 days, with only 2 hours a day, so in total 10 hours stimulation over 5 days, we had lasting effects for at least an average a month. And that's very important. That was also reproduced by a couple of other groups independently. We did a proof of concept in Parkinson patients where the electrodes were implanted, the cable was not yet implanted, and the generator was not yet implanted. In other words, patients were externalized, and so that we could stimulate them by means of a safe and very beautiful portable stimulator externally, and we stimulated patients during 3 days. 2 times 2 hours a day, 2 hours in the morning, 2 hours in the afternoon. And we looked at the motor scores. Patients were completely off medication during this study. And we looked at the local field potential, so the activity and the depth of the brain. And this is how it looks like. A typical patient, so 49 years old patient, right-sided and right-handed patient. She also suffered from a dystonia at that time for more than 1.5 years at the time when the video was taken, and she was instructed to stretch her fingers, but she's not able to do so. And this is now directly before CR stimulation, and you see the pronounced symptoms, so the tremor, dystonia. We measured EEG signals, muscular activity signals, a couple of signals to really understand what's going on. And this is about 20 minutes after turning on coordinated reset stimulation, and you see that the symptoms are remarkably also dystonia, which doesn't respond that well to standard DBS of the STN. And it's important to mention that this was unilateral stimulation, so only one of the contacts electrodes was used. And the important point is this is 1 hour after turning off stimulation, and they see from a clinical perspective that the symptoms persist. So it's very different compared to the first video where I've seen that the symptoms come back immediately, but the symptoms persist, and that's important. And this is what we've seen that's the same patient, and we stimulated unilaterally, as I said. Nevertheless, in all patients, we had full-blown bilateral effects. And we recorded from the electrode pair that we also used for stimulation. And so what you see here is the spectrum, so-called power spectrum. So the x-axis gives you the hertz, the frequency, the rhythms, so to speak. And the y-axis is the power spectrum, spectral density, and this is before stimulation. And you see the pronounced tremor-related peak in the range of 5 hertz, and this is the so-called beta band peak in the range of about 18 hertz. And this is 1 hour after turning off coordinated reset stimulation. After in total 4 hours stimulation, so patients received in total 4 hours stimulation, and this is 1 hour after turning off stimulation. And we see that the rhythms didn't come back, these abnormal rhythms. It's very different compared to standard deep brain stimulation, where, for example, this peak comes back within 12 seconds. Now, on the one hand, deep brain stimulation is a super important treatment, and we are further working on an optimization, also computationally. We are also in the process of planning an implant study in chronically implanted patient. However, one of our goals is to provide patients with a non-invasive option, stimulation option. And this is why we're tactile coordinated reset stimulation. And it was also based computationally. So the computational prediction was it should be possible to do the same thing non-invasively. Although, for example, when you stimulate the fingertips are far away from the brain. But the good thing is there are clear anatomical pathways that lead to centers in the brain that we, well-defined centers, that we can stimulate in a very well-defined way that fits very well to our type of stimulation. And we can spare stimulation of other unwanted regions. And there's an important series of studies by Lenz and his group, Weiss here, for example, as first author. What they've done is in Parkinson patients, they've also shown it in patients with essential tremor, with dystonia, with chronic stroke. What they've shown is the following. When they recorded from neurons in the central hub that's responsible for proprioceptive feedback, meaning that receives all the information from the skin concerning touch, concerning vibration, and all this, these neurons discharge in a rhythmic way coupled to the peripheral vibration. And that's for the engineers and those who are interested in it, it's the so-called cycle histogram. So this is one cycle of the peripheral vibration. And this is one typical example of such a neuron. And you see that's the histogram. So without any relationship between the vibration on the one hand and the discharge, this would be a flat, a noisy flat distribution. But what you see is a beautiful so-called noisy phase entrainment. And that's what we need, because our approach does not need to stop neurons or induce very high rhythms or things like that. Our approach needs to control the timing patterns of neurons so that the neurons are no longer in synchrony, but we disrupt it We disrupt the strong abnormal rhythms so that neurons discharge at different times, or different neurons discharge at different times. Now, why the fingertips? If you think of Penfield's homunculus, this little man, beautiful man, shows you the following, and there are more modern versions of it, at least for the motor cortex, but the essential message remains the same, and that is the fingertips are a very small portion of the skin, represent a very small portion of the skin of the entire body, but the corresponding brain area that is the neurons that respond to activation, for example, vibration of the fingertips, is large, comparably large. So in other words, we have a nice entry point. There's a large area in the brain that we can reach out to, that we can activate in the way we want to do it in order to do coordinated reset. And therefore, and this was the first generation type of stimulation, so we replace the electrode with a couple of stimulation contacts by means of a glove with vibrators, fingertip vibrators. And instead of delivering electrical bursts to different stimulation contacts, you stimulate vibratory bursts, brief vibration, non-painful, not too strong vibrations through different fingers. For example, finger 1, 2, 3, 4, channel 1, 2, 3, 4. Here you see the vibration pattern, and it's basically the same pattern as you've seen before for the deep brain stimulation case. So we have these period is in this case slower. It's 1.5, corresponds to 1.5 hertz. It's very convenient. Many subjects, also healthy subjects, reported as being very relaxing. 3 cycles on, 2 cycles off. We do not want to stimulate the brain permanently. There should be pauses, and these pauses are good in order to exploit the desynchronizing effects on the one hand. On the other hand, neurons should also do their normal information processing. We don't want to overload them by stimulation, so to speak. And I'll show you now some data and then videos to illustrate what these bars and all these points and everything means. We, pre-pandemic, we were doing a 3-month pilot study, and we wanted to enroll 20 patients and do a 2-year study. But then, unfortunately, due to COVID, we had to stop in-person assessments after 3 months. We were able to assess a few patients considerably longer, and I'll come to this in a few minutes. An important point is for the next slides is when I show you these MDS UPDRS Part 3, the standard motor scores, all of them were obtained after thorough medication withdrawal. So the patients had to withdraw their medication between 12 hours and 48 hours, depending on the half-life of the medication. Then the patients came in the morning at 8 a.m., being off medication, and we performed this MDS UPDRS Part 3 score, and the patients received the glove treatment for 2 times, 2 hours, in total 4 hours in between a lunch break, and then at around 3 p.m. in the afternoon, again the same motor exam, and again off medication. So the patients didn't receive any medication the entire day until something like 4 p.m. And you see that statistically there was an improvement. They improved. They didn't get worse, although they didn't get the treatment, but they improved. Now, we also looked at long-term effects. So on a different day, patients came in, again, after medication withdrawal, in the morning at 8 a.m. And then they went home with a glove. They were stimulating between 2 and 4 hours a day in total for 3 months, and came back again were assessed after medication withdrawal. And you see this again, significant improvement. So the patients didn't get worse over time or stayed the same. They actually improved. Now let's look whether because that's important. Is it just a statistical improvement? It's a clinically significant improvement. And then the beautiful thing is that, in this case, we have to look at the so-called MCID, the minimally clinically identifiable difference. And that means the following. If the motor score of the patient decreases by 3.25. It's clinically significant. It just reaches an extent where patient says, oh, I'm feeling better. And the green bars tell you the improvements on the first day. Very first day, we looked at these acute effects, two times 2 hours. So they were stimulated patients in the morning. We measured them in the morning at 8 a.m., didn't get any treatment, any medication, but 2 times 2 hours glove treatment. And then again, we did the motor scores at 3 p.m. And you see that all of these patients, except for patient 3, had a clinically significant improvement. Patient 3, at least, although everybody was off medications, did not get worse. And then the orange bars show you the improvement of the patients over 3 months. So they came in after 3 months using the glove and of being on the normal medication, using their glove, often reducing their meds. And again, after medication withdrawal, they were assessed after 3 months, and all of them showed a clinically significant improvement. This is the entire amount of medication, and it decreased from baseline, the start of the study, till 3 months. Here's a finding I didn't expect to be perfect, or we didn't expect, to be perfectly honest, because it's so pronounced. And so what we did was we recorded the EEG in all patients, again, also off medication, in order to avoid any interference with medication. And this is the power. So we did this analysis for every single patient, and then we projected the results on a reference brain, Montreal Neurological Institute's reference brain. And this is the primary motor cortex, sensory motor cortex regions of the sensory motor region. And the only difference in that region, statistically significant reason between the prior to treatment, after 3 months of glove treatment, was found in this high beta band, so in the typical Parkinson's related frequency band. And already by visual inspection, you see the huge difference, and it's statistically, of course, clearly significant. You see very much neuronal synchrony before the treatment and considerably less after 3 months of treatment, which is certainly encouraging because it's not so easy to find good markers in the EEG. We did longer case series studies, also a large series of compassionate use treatments in Europe. And here the 6+ months case series study. So what you see here is the x-axis is days of vibro-tactile stimulation, and the y-axis are these motor scores off medication. All of these dots correspond to an off medication motor exam, so done after really pronounced correct medication withdrawal. And the interesting thing is, so this amounts to some like 9 months. This is about 6 months. These are 6 months with 2 times 2 to 4 hours a day. This is 1 month pre-planned pause. Another 6 months with maintenance dose, only 1 to 3 times 2 hours a week. And you see that there's a linear decrease on average. And that's the important point. So patients do not get worse, because it's been shown in a couple of studies, nicely shown that patients do get worse over time, that the disease progresses. And this is very encouraging in the sense that we see patients getting better when assessed off medication. We also follow up 3 of the patients in this pilot study, and they received 6 month stimulation, 2 to 4 hours a day, 1 month pre-planned pause, 6 month low dose maintenance, and they had after effects for after sending back stimulators, between 1 year and 1.5 years. Now, all these were bars, dots, and so on, and therefore I'd like to show you a few videos in order to illustrate that. So this is a patient who was diagnosed in 2007. He took a large amount of medication. It was basically 50% of his off time per day, often lying in bed because he wasn't able to move. He used a chain, was supposed to use a wheelchair, and here he is simply instructed to enter a room. This was close to his best on, medication on state. This was July 2018. And you're unfortunately familiar with all these symptoms, so the small steps, the arms are not swinging, facial expression, there's no facial expression, and it goes on like this. And the patient then came to us in August 2018 and told him to take as much medication as needed in order to feel really well. There was no instruction to reduce medication. Patient dropped down to 6 on the first day, and he had 6 to 7, and afterwards you will hear in more detail how it evolved. So considerably less medication, and this was the patient on the first evening. So you see the nice large steps, the swinging arms, and facial expression was back. And this is the 6th day of vibro-tactile stimulation. He started off with 2 hours per day. This was at home. And he was able to restart working. And we were quite surprised. These were some of his notes I'm allowed to share. We were quite surprised because we didn't expect it, because his sense of smell and taste came back to quite an extent. And that's something we've also observed in other of our patients. For example, one patient had was able in the Pennsylvania smell test to detect just one odor, wood fire. And after 3 months of gloved use, he was able to detect all of them again. We have a couple of these patients. And we're just about to start a study that is dedicated on possible improvement of olfaction and vision, because our patients also reported substantial improvement of vision. Vision issues are part of Parkinson's too. And then finally, November 2018, the patient, not being a runner before, was able to do the New York Marathon for the first time. And then in October 22, he did the Floridian Triathlon, and he's in really good shape, as you'll see afterwards, after my presentation. Here's another patient. He was diagnosed early onset patient at the age of 27. He did lots of workout in an attempt to improve his condition. And then finally had issues doing the workout simply because of the right side. He's off medication. Here you see very, very pronounced way because of the tremor and the balance issues. Here's this pull test shows the balance issues. And this is the video he sent me after 6 weeks of glove treatment. And till now, he initially was scheduled for DBS, and he canceled it, and till now, till today, he doesn't need it. So, and this is another patient who had severe shuffling issues. He also went off medication, and he is off medication after medication withdrawal. So this is the first visit, first day in the morning, off medication. And you're unfortunately aware of the fact that the shuffling kicks in particularly strongly when a patient has to restart, change directions, change velocity, enter exit rooms. And how we provoke it is we ask patients to turn around in long, comparably narrow hallways, and that's what you see here. So this is the pronounced shuffling, and sometimes for the patient it was really difficult to get into a normal mode of walking. That was the symptom he was suffering from most, that he was sometimes in this jogging type of not normal, smoothly walking mode. And this is a video that I think nicely illustrates what you need when you do this treatment. You need patience, because it builds up over time, it uses plasticity mechanisms. These plasticity mechanisms are slow. For example, if you think that you want to, or we use similar plasticity mechanisms that are also used, for example, for learning to play an instrument or so. There's nothing that happens in an afternoon or so, but it takes time. And this is the patient after 3 months. Again, off medication. So comparable situation as in the previous video. And you see the patient has improved, but he's certainly not perfect or so. So the right arm is not swinging. When asked to turn around, it's also shuffling, but considerably less than before. At that time, he already told us that shuffling is no longer an issue for him when he went on medication, when he takes his medication. And that's the reason why we, as it's a common practice in deep brain stimulation studies, why we study patients off medication. This is video I received after 5 months of glove treatment. And this is what he sent me after 6 months and a 1 month pre-planned pause. He was one of the 3 patients we were able to follow up remotely. And what we're doing now is, what we've done so far is the following. Or in the meantime, is the following. We've developed a new glove system, a very professional type of glove system, but very improved type of fastening mechanisms, so that we are sure that stimulation is delivered in a more reliable, more robust way, but nonetheless very comfortable way. That's one thing. The other thing is the new controllers enable us to deliver enhanced, further improved stimulation patterns. We have a very clear clinical development, research development strategy, because one important, so we're going to start with, we have already started 2 weeks ago, we have started with pilot studies in an advanced stage. Parkinson patients will soon start in an early stage Parkinson patients. There are a couple of things we have to learn and to make sure we understand. And next will be a controlled trial where we have a sham stimulation control to make sure that the effects are not placebo. We don't believe that they are placebo, because also tremors, Parkinson, our patients responded also extremely well with respect to tremor, and tremor normally does not respond well to placebo effects. Also, placebo effects fluctuate over time, whereas our patients really continuously improved and for a very long time. And but nonetheless, we will do this in a very rigorous way. Of a fantastic team of neurologists and neurosurgeons who will be part of the entire project. And then as soon as we'll start the randomized controlled trial, and midway we'll have interim results, there will be an FDA approval trial in a very large cohort, and it's with very, very professional people involved in the medtech field. And I want to thank everybody, or the core team, that is everybody in my lab, wonderful lab, and then fantastic neurologists, neurosurgeons, and first-rate statisticians, and all the funding sources. And I want to thank you for your attention. And it's now a super great pleasure for me to introduce Kanwar Bhutani. Kanwar is a truly exceptional person. I mean, he served as president of Tupperware, as well as president of Avon Philippines and president for Jeunesse Global. He demonstrated a proven history of leadership. He has a huge success story to tell, and consistently established a clear systematic growth strategy for businesses and transformed companies in declining sales into top performers. He's a wonderful person. He served on the boards of Boys and Girls Club of America and the Osceola Medical Center. And as I said, he's truly exceptional. I am very grateful for our interaction. It was always a super great pleasure for me to interact with him, and it was also a deep satisfaction to help him. And I want to thank you very, very much for having me. It was a great pleasure to join you. Unfortunately, it was not possible for me to come over in person, but thank you so much. I really appreciate being part of your meeting. Thanks very much.
Thank you, Peter.
Ladies and gentlemen, a big warm welcome for Kanwar Bhutani.
Thank you. Thank you. So you see me wearing these gloves. These are the same gloves that Peter talked about in his presentation. But I don't need to wear them to be able to speak, because I'm overdosed right now. Because, and not from cannabis, but from the gloves, believe it or not. So I'm going to take them off, but I just wanted to show you what they look like. And it's fairly easy to pull off. The new version is not going to have all these wires. It's Bluetooth. So it's going to be much more easier to use. But anyway, it's an honor to be here today with all of you. And, you know, my story is probably not much different than your story, you know, except we had Parkinson's at different times. And one of the things that the speakers said this morning, many of the speakers said, don't let the disease define you as an individual. Take control of it. I want to thank the Neuro Challenge Foundation for putting this event together. It's an absolutely wonderful event and great nuggets of learning that we learned from each of the doctors this morning and this afternoon. And I'm hoping that I could, as we close today, hoping I can summarize my journey and share some nuggets with you that people have shared with me over the years that have helped me, and it can maybe help you. And we can keep in touch, and that way we can exchange ideas going forward, because one of the best things I find is with patients is that we have a community around us and support groups. We can learn from each other quite a bit. The doctors will tell you one thing, but it's immediate family and close friends which will share with you what their personal experiences are. Would you agree with that? So how many of you, just to show of hands, have PD in the room? Okay, and the rest are caregivers, I assume? Okay, and then physicians, I know we've got physicians here as well. So my journey started when I was 39 years old. So I'm turning 60 next week, so it's been about 21 years. And it started with basically pain in the elbow. And I was wondering what it was, so I went to an orthopedic and I got 12 cortisone shots over a course of 6 months, but no improvement. And then he said, let's do an MRI. I said, sure, do an MRI. He said, you've got a tear in the ligaments on your elbow, so we've got to repair the tear. So I scheduled the surgery, and then I went away for a vacation for a while, and I decided on vacation that I'm not going to do surgery. And it was probably the wisest thing I did, because it wasn't a torn ligament, it was Parkinson's. And then it gradually spread to my hand. My handwriting started getting smaller. And it spread to my right knee, and then my left side. And then I was pretty much, when I went to the doctors, they'd given me 5 years to say that you'll be in a wheelchair. And when I heard the word wheelchair in 5 years, I was 39, and I said by 43, 44, I'll be in a wheelchair. There's no way that's going to happen. So my wife got a wheelchair just as a precaution for insurance for us. But I threw it out right away. I said, I'm not sitting in that chair if I don't have to. And I'm going to keep moving and do what I need to do. But it wasn't all rosy in the beginning. You know, the first time when I got diagnosed, it was basically a feeling of why me? Why did it happen to me? And you probably can relate to that, many of you in the audience, right? And you probably had anger, you know, and questioning yourself, what did I do wrong? What did I consume? What did I eat? Did I have mold in the house or whatever? We don't know what the cause is, but you know, they say it's pesticides or something like that. But what could it be? So you try to start think back, and what are the things you may have done? But you really can't find any answers. Then you look genetically, if you had anyone in the family who had it, and then that gives you some answers as well. So my wife always reminds me of this slide. Tough times never last, but tough people do. You know, we've got to be warriors with Parkinson's. Can't be victims of the disease. We've got to be warriors and get it head on. I know it's tough getting up in the morning sometimes and getting up and doing some exercise, but you've got to do it. That's 50% of the battle right there. So this is what I went through when I got diagnosed. Shock. I was in total shock because I walked into the doctor's office I had no idea what Parkinson's was, quite honestly. So I walked in the doctor's office. He had me walk 6 steps. And then he said, "You've got Parkinson's." So I was like shocked, and I said, "You've got to be kidding me." So I thought of every single 4-letter word I could think of at that time and walked out of his office. I mean, it was a big thing, and I said, "I don't even know what Parkinson's is." I've heard of James Parkinson's. He was the inventor of Parkinson's, if you will. But I thought it was for old people, and I was 39. And so I kind of went into social distancing, if you will, my own COVID version, where I didn't go out of the house for probably the first 6 to 7 years. I didn't want to tell anyone. I quit my job, and I was on the top of my game in my career, but I said, no, I'm going to focus on my health. But rather than focusing on my health, I was focusing on poor me, sitting on the couch all day, not doing anything about it, and not wanting to meet anyone. You know, you heard the doctors talk about socializing, interacting with people, extremely important, getting out of the house. So my wife was a big support in this. She couldn't be here today, but she was a big support in terms of caregiving for the last 20 years. She's been by my side to help me out. Unfortunately, during the same time, she was diagnosed with stage 4 endometrial cancer, and she was given 2 weeks to live. So our life was totally up in shambles, you know, with me with Parkinson's and a poor me mentality, and then she with her cancer. So we had to make some adjustments quickly and start saving for the long term to be able to support our illnesses. So there was a lot of disbelief. There was denial, the victim mentality, and why me? And one thing you'll see with the disease, it doesn't discriminate at all. You know, no matter which religion you are, what political views you've got, it crosses all boundaries. It doesn't discriminate anyone at all. Would you agree? So first 10 years was poor me mentality, as I mentioned. Didn't want to engage with anyone, given up. No one knew, no one at work knew. So whenever I'd walk into work, I'd be walking like this, sort of. And they said, "What's wrong?" And I said, "I've got a back problem. I had an accident." And which was partially true, because we did have an accident, and I messed up my L4, L5. But it wasn't that, it was Parkinson's. But I wasn't ready to tell them, and that's probably the biggest mistake I made, not telling people at work. And like I said, I thought it was for people over 65. And my kids were still in school at that point. We didn't want to tell them, so I told them about 10 years ago. They actually found out by accident when they found some papers on Parkinson's on the printer and said, "What are you doing with Parkinson's papers, Dad?" I said, "Well, I've got it." So that's kind of how they found out. So that's my family there, my wife and my 2 boys. So then what happened was, after the first 10 years that I was in denial, I started going public with it and started telling people about it. And that's the best thing I did, because one thing led to another. I told a friend of mine at Disney on the left, the couple on the left with Michael J. Fox, told them that I had Parkinson's. And so very quickly, within a month, he arranged for a meeting with me and Michael J. Fox. And I got inspired by talking to Michael and hearing his story, because he was also diagnosed at a very young age, and he's got deep brain stimulation. And so I started fundraising for his organization. We were the highest ranking fundraiser in 2018 for him. But we got to know each other quite well, and we've been supporting the foundation. The reason why I bring this up is, get involved. You know, you're the one who can make a difference. When you get involved with organizations like the Michael J. Fox Foundation, the Neuro Challenge Foundation, these are good organizations you should be involved in, the support groups, the community groups. I didn't in the first 10 years. I neglected to. But in hindsight, I should have. And what happened was, along this journey in 2018, I was still struggling, but I attended one of the similar conferences in Orlando, and I met the gentleman on the right is Jimmy Choi. He's from American Ninja Warriors, and he's got Parkinson's. So then I met someone else, Tanya, in the lower picture, and she was a prominent lawyer in Orlando, and she's got Parkinson's, and she was my age. And I said, okay, so there's someone finally my age who's got Parkinson's. So I contacted her, spoke to her, and she said, well, I just did the New York Marathon last year. I said, you did? So I'm very competitive. So I said, you know, I'm going to do it myself, but I'm not a runner. I've never run in my life before. So I started practicing. I got a coach, started practicing, and I was afraid of falling, but I said, you know what? What the heck? We can get stitches put in. It'll be fine. I'm still young. And in 2018, I ran the New York City Marathon for the first time. And that was because the support from friends and family, because I found out about things, that if they could do it, I was up against the challenge. But also because of the gloves that Peter introduced me to. Now, coming to the gloves. Total stranger. Sometimes they say destiny is it's meant to be, and you can't control it. Well, what happened was we've got an apartment in New York, so I was trying to get into the elevator. And as you know, tight spaces are very difficult for Parkinson's patients. What happens? We freeze, right? So I had a cane, and I was trying to get in, and I was going like this, and shuffling, and the elevator was full of people, and it was taking me about 5 minutes to get into the elevator. So the first thing I said, they're probably thinking, what's this guy with a turban on his head coming in the elevator for? So when we got past that, I said, I'm not drunk, I've got Parkinson's. So that's all I said, because I wanted them to know I wasn't drunk, because that's the first thing they think you are. So when I said that, on our 14th floor, a woman gets off the floor, and this was the woman who got off the floor and said, excuse me, sir, if you've got Parkinson's, there's a doctor at Stanford called Peter Tass. Give him a call. He's got some cutting-edge stuff he's working on. So it was a Sunday afternoon. I said, he's probably not going to respond, so let me just send him an email anyway. Sent him an email. Within an hour, he responded. And he said, why don't you come up to Stanford next Thursday? And I literally went to Stanford in a wheelchair. And those videos you saw that Peter shared, that was day one of my treatment with these gloves. So, and this was a stranger that we met in the elevator who told me and disappeared. And 6 months later, I met her in Stanford. But she was the one. So it was just happened to be in the right place at the right time, and met someone who took me under her wings, and I call her my angel after I met her. And she happens to be a friend of the #1 patient who went through the glove treatment. I was the #2 patient in the world to go through the glove treatment. So like I said, get involved in foundations. They need you, and we need them. Because without them, we're not going to find a cure, guys. We've got to find a cure for this disease. It's debilitating, and it's something that I don't wish anyone has, because when you live it every day, you know what it feels like. Local foundations like the Neuro Foundation, Neuro Challenge Foundation, is a wonderful group to join if you're not a member already, and get involved in their support meetings. Another organization I've found very helpful is the American Parkinson's Disease Association. They've got very good content, and they've got a lot of videos online, so on different subjects, if you want to look up stuff, they're very informal. We've got a walk coming up for Parkinson's on Saturday, April 6th. If you would like to join us in Orlando, please feel free to. There's no charge for it, but it's our 10th anniversary walk. We'll have about 1,500 people. So we'd love for you to be a part of it. So get involved. What do I mean by that? Well, ever since I got diagnosed and I got out of the poor me mentality, I've been running. Like I never ran before, but I've been doing 5Ks almost every month. And I've been doing, with Michael J. Fox Foundation, we've been doing golf tournaments, we've been doing wine tournaments, whatever your passion is. One of the individuals talked about, one of the doctors talked about your passion. Whatever you like to do. If you like to drink wine, do a wine tasting. We did a fashion show with Bloomingdale's. We teamed up with them. We did a fashion show for Parkinson's. So there's a lot of creative things you can do, and just be involved. So then last year, I decided that I was going to do something different. My son calls me up and he says, Dad, what do you want to do this year? You did the marathon, and then we had COVID. I said, let's try to think of something creative. He says, why don't we do the Ironman? I said, no way, Ironman's not possible. And he said, well, I'm doing it. I said, okay, you do it, and I'll watch. And then he said, well, why don't we do the triathlon? And I said, yeah, sure, let me try that, because I can swim. I know how to swim, I know how to bike, and I know how to run. So I can do that. It's just all three together at the same time, one after the other, could be a challenge. But I wasn't looking to be first in the race, just looking to finish the race. So last year I did my triathlon in Claremont, my first ever triathlon. So I bring this up because it's not because it's a triathlon, but it's exercise. Swimming, bicycling, walking, running are good forms of exercises. And doctors will tell you that 50% of the battle, it's not even the medications, it's not even the gloves, it's exercise. If you exercise, like today, I feel a little tight because I haven't exercised this morning. I was on my way over here. But normally, when I exercise, I feel like I've got a full day. Because this is about the time we Parkinson's patients need to go to sleep, at this time, right? So get involved. I can't stress that. And, what I found was there's a whole other world out there. When you tell people about your disease, you don't want them to be sympathetic. You want them to understand it so that you know where they're coming, they know where you're coming from. But at the same time, they'll find resources for you and tips in terms of where you can get support. So this is Peter Test, the trials that we did. It was very exciting. We had no hopes when we went there. We had given up and we said, okay, we'll give it a shot. It's not invasive. We'll just try it. If it works, it works. If it doesn't work. But it worked. Now, in addition to the glove treatment, there's a few other things that I want to stress that are important as well. Gloves don't replace DBS. DBS will still need to happen at some point or the other. You can prolong it with the gloves, because I was a candidate for DBS about 5 years ago, but I haven't gotten DBS done yet because I'm still using the gloves. But eventually I know I will need DBS. Frequency of use, I used to use the gloves 2 hours a day in the morning, 2 hours in the afternoon for the first year, and then I got overdosed because I had dyskinesia, moving all over the place, and my medicines hadn't been titrated, and at the same time the gloves were giving me stimulation, so I went to 2 hours once a day, and then I went to the third year, I went to 1 hour twice a week, and then the fourth year I just use it as and when needed. So I use it maybe once or twice a week because it builds dopamine in your system, so you've got excess dopamine. So you don't want too much of it, then you'll be bouncing around all over the place. Tremors and stiffness, I had quite a bit of it, and now I'm much better with the gloves. Taste and smell. Many of the doctors talked about you lose your sense of taste and smell. I'd lost all of it. I have 60% of it back as a result of the gloves now, so I can taste and smell stuff. Before, when people used to ask me, how's the wine tasting? I said, excellent, but I really couldn't taste it. And the UDPRS score, that's a score that you're all familiar with. My score when I went for the gloves was over 60. And it went down to under 20 consistently with the gloves. So exercise, therapy, biking. Biking is one of the best forms of exercise for Parkinson's patients. And if you're worried about balance and falling on the streets, you can do a stationary bike, same thing. I do about 10 miles on weekends each day, biking, and I walk about 3 miles every morning with tools that I'll show you in a bit. Medications and doctors. Dr. Latia talked about the Innovation Tower at Advent Health. That's a beautiful facility. I've been there, and they've got everything. It's one-stop shop. They've got everything in one facility. And Orlando Health is also building a neuroscience center, which will be open in April of 2024. So Central Florida is going to be the destination for neurology, and that's what we're trying to create with the Central Florida Foundation. Titrating medicine is important. The pharmas are coming out with some neat medicines. There's some great medicines that have come out in the last 6 months that improve your quality of life. There's no cure yet, but there's improvements in quality of life. And the timing of medicines is very important. Dr. Latia mentioned, 30 to 60 to 90 minutes before or after meals. I'm a strong believer of that because proteins really does interfere with the medicines. So I take medicines an hour and a half before or after meals. And then, how many of you take carbidopa levodopa? How many of you have problems when it doesn't kick in? It takes an hour and a half to kick in. It's miserable, isn't it? So what I do sometimes is if I'm in a hurry and my medicine doesn't kick in, I take carbidopa levodopa, put in some seltzer water, any carbonated water, and let it dissolve and drink it. It absorbs in 15 minutes. So that might help you as well. Medication supplements. Just want to share with you what I take. This is by no means what you should take because each patient is different. You need to check with your doctor. But virgin coconut oil for cognitive function, I take that every day in the morning. B12 slows the progression for motor and cognitive function. CoQ10, citrulline, and reduced glutathione. Then I take biotin, calcium, mucana powder, which is a herb plant from India, which has natural levodopa in it, and lipoic acid. Diet. I know the doctors talked a lot about Mediterranean diet. This is basically what my meals consist of. Breakfast, oats, bananas, assorted berries, papaya, multigrain, bread, green tea, and eggs once a week. I try to avoid dairy. And lunch, I have salad, chickpeas, lentils, zucchini, eggplants, carrots, broccoli. Afternoon snack, homemade popcorn. Try to get stuff that's not preserved, just fresh stuff. And dinner, leafy green vegetable salads, and rice, chicken, fish, and steak every now and then at night. And then what I do is for protein, I have a bottle of Ensure, the protein shake. Just drink that at night, so it really doesn't conflict with your medicines at night. We talked a lot about what limited salt, limited sugar. I try to avoid that, no salt, no sugar. And we cook in olive oil, pretty much. And organic fruits and vegetables. Constipation, what I use is senna leaves. You can buy it off Amazon, senna leaves. And take some rock sugar and fennel seeds. And 4 parts senna leaves, 1 part rock sugar, 1 part aniseed, aniseeds. And then blend it together in a coffee grinder and have a teaspoon of that, and you'll be perfect, ready to go to the bathroom. And then, or tamarind, raw tamarind, I use that. That serves me well as well. You know, just eat a little raw tamarind. Proper hydration is extremely important. You heard many of the doctors talk about that today. And, you know, there's a saying out there that you need to drink 6 to 8 glasses of water a day. But, you know, there's no scientific evidence behind that. It's one size doesn't fit all. And plus, the water we drink today, it doesn't hydrate you properly. It just goes through your tissue. And it goes into your tissue, and it doesn't go to the cellular level. It just goes to the tissue and out your body. And you're in the bathroom constantly. And so I'm actually consulting for a company now that does water hydration. And I joined them specifically because of the water they provide. And that's benefited me. I'm not saying that this is the only water available in the market. There's Kangen water, there's hydrogen water, alkaline water, and they've all got their benefits. But look at investing in some water for yourself, because this regular water doesn't really do it. Because this, particularly in plastic bottles, it's got leaching from the plastic that is dangerous to us as well. And so, you know, proper hydration is important. Your body needs the minerals and amino acids and electrolytes to really function and be properly hydrated. So everyone got a cell phone? Get your cell phones out for a second. Get your camera ready. Okay, what I've arranged for through my company that I'm consulting with is a free case of 12-pack for each of you here. So just scan the QR code. You don't pay anything for the product. You just pay the shipping cost, which is, I think it's $9.50, but you'll get a 12-pack case. It comes in a sweetened and unsweetened version, and you can try that. And it's worked for me. I take 2 cans a day, and it hydrates me properly, and I feel fine, and I've got energy to get through the whole day. So these are the tools I use in my toolbox. You know, one of the things, what happens with Parkinson's patients, we tend to hunch forward, right? So the exercises we need to do is make sure our back moves backwards. Our upper body is backwards and our lower body is forward. So I use a harness there that you can see on the top left. It's just off of Amazon. So when I go for my morning walks, I just put it on. It's just a strap. It's like a backpack, but without the backpack. And it just keeps my body straight. So I don't hunch when I'm walking. Because there's a tendency to, when you're shuffling, you're moving forward, and you try to avoid that. And then, of course, I keep a cane, a portable cane, and then I've got a waist belt, you know, for back problems, because we tend to have lower back problems. And then Viraball is something I came across, which is a vibrating device, which is a ball, and there's quite a few of them on Amazon, different kinds of them, different kinds of brands. But basically, you put it in your hand, and I carry it, put it in my hand and carry it, and it just vibrates in my hand, and gives me good feelings after that. And then what's it called? Hand strengthener. So I use that in one hand and the Viraball in the other hand. And then I've got electrical stimulation, the TENS device that I use every now and then. If I've got real back problems, I use the TENS device at home. And then, of course, a massage chair. So that's what I use. But you know, the key thing is get involved, have hope. It's not the end of the world. Look at people around us. It could have been worse, you know. But there's a lot of good stuff that's been going on, and lean on each other for support. lean on, feel free to call me anytime. I'm always accessible because for Parkinson's, I'm a strong advocate of Parkinson's patients because I want to try to help as many people as I can out there, with my knowledge and what I've learned, and plus at the same time learn from them on what they've learned. And I think it'll make us very powerful together if we share information with each other. Some of the foundations I've worked with in the past, which have been very good, Medicare.org, of course, has great information for Parkinson's patients in terms of what in-home therapies they can provide. The Assistance Fund, which is an Orlando-based company, they provide funding for medicines that are very expensive and copays are very high. They'll provide funding for that. Pan Foundation is another foundation out in the Northeast. They also are, you might be familiar with them, they also provide funding for copays. And then AARP is very useful as well, that I get good source of information from. So, let's keep in touch and hope you found this helpful. And I'm sure we'll get some time offline to talk as well. Thank you.
Ladies and gentlemen, let's give Conwar a big round of applause and thank you for making the trip over from Orlando. Thank you. Thank you, Conwar. We appreciate you so much. So, ladies and gentlemen, thank you all so much. Have we not had a fantastic day today? Yes? All right. So Brad wants to get a picture of all of us that are left doing a big wave. So let's everybody give a big wave. Make some noise. There we go. Woo! Celebrating the 7th annual Expo. There we go. So thank you to all the volunteers who have helped make today possible, to the staff, to all of you for hanging in there with us all day today. We hope you have found all the speakers informative and educational and that you've enjoyed it. And make sure to follow the Neuro Challenge Foundation on our Facebook page, on our website, sign up for our newsletters, and we certainly hope to see you at one of our monthly programs. We've got a very comprehensive program calendar on the website, so check it out and come join us, and then follow us as we will be ready to announce the 8th annual Expo in spring of 2025 very soon. So thank you all so much. We have enjoyed having you here with us today. Travel safely and enjoy the beautiful weather. Thank you all.
What you get is what you
Could all Neuro Challenge staff and volunteers make their way to the photo booth area? Neuro Challenge staff, find your way to the photo booth area. Thank you all, and everyone, drive safely.
Hear the children crying. Hear the children crying. Saying, give thanks and praise to the Lord, and I will feel alright. Saying, let's get together and feel alright. Whoa, 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 whoa. Let them all pass all their dirty remarks. There is one question I'd really love to ask. Is there a place for the hopeless sinners who has hurt all mankind? Just a Savior's own belief. One love. What about a one heart? What about let's get together and feel alright? As it was in the beginning. One love. So shall it be in the end. One heart. Alright. Thanks and praise to the Lord, and I will feel
Ooh, yeah. Yeah. So won't you dance? Clock strikes upon the hour and the sun begins to fade. Still enough time to figure out how to chase my blues away. I'm gonna ride up till now. It's the light of day that shows me how. And when the night falls, loneliness calls. Oh, I wanna dance with somebody. I wanna feel the heat with somebody. Yeah, I wanna dance with somebody. With somebody who loves me. Oh, I wanna dance with somebody. I wanna feel the heat with somebody. Yeah, I wanna dance with somebody. With somebody who loves me. I've been in love and lost my senses, spinning through the town. Sooner or later, the fever ends, and I wind up feeling down. I need a man who'll take a chance on a love that burns hot enough to last. So when the night falls, my lonely heart calls. Oh, I wanna dance with somebody. I wanna feel the heat with somebody. Yeah, I wanna dance with somebody. With somebody who loves me. Oh, I wanna dance with somebody. I wanna feel the heat. Yeah, I wanna dance with somebody. With somebody who loves me. Somebody who loves me. Somebody who to hold me in his arms. Oh, I need a man to take a chance on a love that burns hot enough to last. So when the night falls, my lonely heart calls. Oh, I wanna dance with somebody. I wanna feel the heat with somebody. Yeah, I wanna dance with somebody. With somebody who loves me. Oh, I wanna dance with somebody. I wanna feel the heat with somebody. Yeah, I wanna dance with somebody. With somebody who loves me. Come on, baby. Yeah. Now get with this. Whoa, don't you wanna dance with me, baby? Don't you wanna dance with me, boy? Hey, don't you wanna dance with me, baby? With somebody who loves me. Don't you wanna dance? Say you wanna dance. Don't you wanna dance? Don't you wanna dance? Say you wanna dance. Don't you wanna dance? Don't you wanna dance? Say you wanna dance. With somebody who loves me. I got a feeling that
tonight's gonna be a good night. That tonight's gonna be a good night. That tonight's gonna be a good, good night. I feel it. That tonight's gonna be a good night. That tonight's gonna be a good night. That tonight's gonna be a good, good night. I feel it. That tonight's gonna